Hello everyone, we'll start shortly. We're just waiting for everybody to sign in and settle down. Shall we start? Good afternoon, everyone, and a warm welcome to this webinar. So we are MedGenome, Leaders in Genetic Testing in India. So we are organized, my name is Joseph, and I'm your host for the session. And we welcome you to this webinar organized by the Association of Obstetrics and Gynecological Society of Delhi and the Delhi Association of Pediatric Surgeons. And the topic for today's webinar is providing quality care in abdominal malformations before, during, and after birth. Before we start, I want to inform the audience that if you have any questions or comments, please use the Q&A window of the Zoom interface and not the chat window. The faculty will answer your question as an your questions. So without any further delay, I'll hand over to Dr. Shilpi Narain, who will take this webinar forward. Over to you, Dr. Shilpi. I'll stop sharing. You can please.
Thank you, Mr. Joseph. I again extend a hearty welcome to all the delegates to this webinar on providing quality care in abdominal malformations. This is under Aegis of Fetal Medicine Subcommittee and QI Subcommittee of AOGD and Delhi Association of Pediatric Surgeons. Without any further delay, I want to welcome you all, and I want to introduce our head of the department and the convener of the webinar, Dr. Manju Puri. Ma'am, please give the introduction to the webinar.
Yes. So a very good evening to all. And I'm honored to welcome you all on behalf of the Departments of Obs and Gynae and the Department of Pediatric Surgery of Lady Hardinge Medical College and associated Sucheta Kriplani Hospital and Kalavati Saran Hospitals. I welcome you to this focused webinar on providing quality care to pregnant women carrying fetuses with abdominal wall malformations during pregnancy, during childbirth, and also care to the newborns after birth. We all know that prenatal diagnosis of fetal congenital malformations has increased significantly over the past 2 decades. And this is thanks to the advances in technology and also to our fetal medicine friends, fetal medicine specialist friends who are really good at their work. So we as obstetricians are often faced with this dilemma of counseling pregnant women and their families when they come to us with reports, ultrasound reports showing that their fetus has got abdominal malformation. In case they're less than 20 weeks, it's easier. Most of them would, opt for termination of pregnancy. But those beyond the legal limit of termination of pregnancy are the ones which would need a multidisciplinary approach. Because not all babies who have fetuses who have abdominal malformation can be disregarded. So a number of them can actually be managed, and the anomalies can be corrected, and they can have a meaningful life. So I think these are the ones who would need a multidisciplinary team approach with an obstetrician, a fetal medicine specialist, a neonatologist, and a pediatric surgeon on board. So this webinar brings together people from all the specialties, and I think this is the way forward. We all are managing the patient to our best, far end, but there has to be a platform where we integrate and we share our experiences. We would know what happens to the baby after the baby is born. So I think this platform will help us share our experiences and give some meaningful messages to the delegates from all the specialists. And we have a galaxy of eminent national and international speakers, a lot of friends. And I'm looking forward to the deliberations, and I hope you all find the webinar useful. It is with a different theme, but I hope we have 3 sessions here, one on antenatal, one on intranatal, and one on postnatal care of these babies. I look forward to the deliberations. So welcome once again. Thank you. Over to you, Shilpi.
Shilpi, you are muted. Unmute yourself.
Thank you, ma'am. Thank you for such an encouraging words about the webinar, and we are all geared up to listen to the experts. I welcome Mala ma'am, Dr. Mala Srivastava. Ma'am, is my slide visible?
Yes.
Ma'am is a senior consultant and professor at Sir Gangaram Hospital, New Delhi. Ma'am is a president AOGD for 2020-2021. And ma'am has been supporting us through all our webinars. Our co-convenor, Dr. S Roy Choudhary, he is also with us as a chairperson. Sir is also the co-convenor of the webinar. I welcome you all. Our director, sir, will be with us soon. Ma'am, should I start the session? Dr. Mala, ma'am, please say a few words about the webinar.
Thanks, Dr. Shilpi. Good evening, everyone. I bring greetings from AOGD. It's my pleasure and privilege to be a part of this e-conclave on providing quality care in abdominal malformations before, during, and after birth, organized by Lady Hardinge Medical College, Department of Obs and Gynae, and Department of Pediatric Surgery. under the Aegis of Fetal Medicine Subcommittee and QI Committee of AOGD and Delhi Association of Pediatric Surgeons. We are so happy that Madam Dr. Manju Puri and Professor Dr. Subhashish Roy Choudhary, as well as Dr. Manisha, has taken up this focused topic. Our subject of obstetrics and gynecology is spreading its wings. As a result, there is flowering and flourishing of various super specialities as well as subspecialties under the roof of obs and gynae. There is rapid advancement in science, so it is a very intelligent option to deal with each and every topic individually in details, rather than brushing through many topics superficially. Such focused scientific deliberations will go a long way in knowledge sharing as well as clearing all our doubts regarding those important topics. I'm sure all the PG students and delegates will highly benefit from today's e-conclave. I wish all success to today's scientific program, and I now hand over the floor to Dr. Shilpi to carry on the day's program. Over to you, Dr. Shilpi.
Thank you, ma'am. Without any further delay, I would like to start the first session and invite the chairpersons for the first session. Dr. Reena Yadav, ma'am is Director, Professor and Unit Head at Lady Harding Medical College. Ma'am, is the screen visible?
Visible.
Yes, it is visible.
Dr. Poonam Tara, ma'am is working as a senior consultant in Max Hospital, Saket and Center for Fetal Maternal Care, Delhi. She has a vast working experience in prestigious hospitals in UK. Ma'am is an RCOG accredited specialist in fetal medicine and a keen academician. Professor Reema Kumar Bhatt, ma'am is a professor and fetal maternal specialist at RNR Hospital, Delhi. Ma'am is executive member of Society of Fetal Medicine and has a number of publications and awards to her credit. I welcome you all, ma'am. Please start the session.
I'm Dr. Reena. Good evening, everybody. Thank you, Dr. Manisha and Dr. Manju, for letting me be a part of this webinar and among these stalwarts in the field of fetal medicine as well as in the pediatric surgery. First speaker for today's webinar is Dr. Manisha Kumar. As you can see the credentials of her. She is a professor and in charge of fetal medicine. And she's keen, her keen interest and focus is totally into fetal medicine, and she has published a lot of publication in that particular subjects only, and she's involved lots of projects in fetal medicine itself. So, and her topic for today is magnitude of the problem at our fetal medicine clinic. As we will keeps on getting referred cases from all over Delhi involving all these problem, fetal abdominal wall malformations and bowel anomalies. Also, she herself does scan and diagnose all these and management and all. So Manisha, stage is yours.
Thank you, ma'am. Thank you, ma'am, for the kind words. And it's really from the encouragement of all my seniors that I'm doing all this. So I will set the ball rolling by giving an overview of fetal abdominal malformations. Am I audible?
Yes, you are, Manisha. Please go on.
So the magnitude of problem that we have at LHMC. So this is the picture of our fetal medicine OPD. We have a fetal medicine facility at LHMC. And when I looked at the data for last 10 years, I found that we had almost 2,026 cases which we had fully followed up. And out of which 197, nearly 10% were GI and abdominal wall defects. And the defects were multiple. Among the GI defects, there were multiple defects in around 31% cases. Most of the women who came to us were young. So the mean maternal age was 25.8 years, and primary gravidas constituted 20% of the cases. Most of the patient came to us quite late in gestation. So mean gestation of diagnosis and referral to us was 29 weeks. And the mean gestation age at delivery was 35 weeks. So whenever the patient comes to us with the antenatal diagnosis of fetal abdominal malformation, we do clinical evaluation and counseling. We do a reviews ultrasound to confirm the anomaly, to look for additional findings, and we do certain investigations which are required. So maternal investigation as well as invasive tests are offered. So out of 197 cases, the patients who came to us before 20 weeks constituted 24% of them, and rest all 3/4 came after 20 weeks. So there were multiple defects and abnormal karyotype in a few of them, and termination was advised in 11% of them. So the patient who came after 20 weeks or had isolated defects continued with the pregnancy. So the pregnancy was continued in 89% of them. So we generally do scan at around 32, 34 weeks before their delivery, so that we have a clear picture of what would be the prognosis, and we also counsel and make the patients aware of what to expect. And then the patient after delivery, we found that around 60% of them had there was live delivery, and these who had live deliveries underwent examination by neonatologist, and pediatric surgery consultation was taken, and they were transferred after stabilization to pediatric surgery if the surgery was required. So if we divide the fetal abdominal malformations into different categories depending upon the ICD-10 coding, we see that the most common of them was small bowel atresias, including the duodenal atresia. This accounted for nearly 24% of the cases. The second commonest was omphalocele, which accounted for 16.2% of the cases. And then the third was esophageal atresia, as you can see, accounted for 14%. Then we had meconium peritonitis and gastrocystis, which accounted for around 12-13% of the cases. Cases with liver abnormalities, calcification cysts were rare, and and also large gut atresias were rarely diagnosed in the antenatal period. Many anal atresias may be missed also at this time. So when we looked at the outcome of our antenatally followed GI anomalies, as you can see here, excuse me. So as you can see here, we had in the omphalocele cases. Sorry, I'm just missing the pointer. Yeah. So in omphalocele, as you can see, the multiple anomalies were most common with omphaloceles. And similarly, the abortions also were most common with omphaloceles. The stillbirths were also most common with omphalocele. And there was very few live birth in omphalocele. And if you just see in contrast, small bowel dilatation, including duodenal atresias, had most live births. And even in esophageal atresias, the multiple anomalies were quite high in number. And similarly, we had very few other abnormalities associated in large gut dilatation cases. So then I come to individual cases. We had this case in which there was very small inconspicuous bowel, but as you can see here, there was claw hand that was there, and there was heart defect in the form of aortic atresia also. So this was radial ray defect with aortic stenosis and absent stomach bubble. Baby was an IUD, and we could see later that there was absent thumb, and so this fitted into bacterial association. For bacterial association, this patient didn't had vertebral anomaly or renal anomaly, but having 3 component features and having essential features are enough. So this was a bacterial association that we have. So as I said, in esophageal atresias, around 50% of them might have multiple defects. Now we had this very interesting case quite earlier, around 8-9 years ago. This patient who had absent stomach bubble and ultrasound outside with polyhydramnios. She came to an emergency with leaking PV and was in labor. She delivered, and after delivery, when we saw the baby had contractures, and there was cataract, and there was a cleft palate also. So the absent stomach bubble was mainly because of the neuromuscular problem that this baby had, and it fitted into Penna-Shokier phenotype. So not all absent stomach bubble would be esophageal atresia. Now, duodenal atresia, as I've said, the prognosis is very good. We had this couple who had the baby had duodenal atresia and was operated very well in the KSCH. And this patient especially came to us to thank us, so that because we had given a good prognosis, telling him that the baby will be very, good after surgery, and there would not be any remnant residual problem. So in contrast to this, we had this another case who had oligohydramnios with duodenal atresia. So that was striking. So when we looked further, we found that there was renal absent kidneys also, and there was no bladder, and we could not very well see the limbs. So when the baby delivered, the baby had cyanomelia. So this also could be one of the features, as we know that there are 30% cases have chromosomal abnormality with duodenal atresia. So we have to warn them of these also. Now, abdominal cyst also, it can be of various, shapes, and as in this case, there is echogenic irregular outline, as you can see here. Contrast to this, in this case, there's a smooth outline. It is on one side. Most probably, it came out to be genital cyst later. And this is a case in which there was a cystic dilatation just beyond the umbilical vein. So it was an umbilical vein varix, which was diagnosed later. And this was another case, was a meconium cyst, mesenteric cyst. Now we have another case, which was a case of omphalocele, came to us at around 19 weeks, 5 days. And it was an omphalocele. We could not see the bladder very clearly. And apart from that, we saw that there was TEV. So we did a 3D, and we found that there was another swelling here, which looked like ectopia vesicae, but we were not very sure. So the termination was done, and we found that it was indeed ectopia vesicae with spinal vertebral anomaly also, which we found later. We couldn't see at that time. So it was a case of OEIS complex. So these cases are rare, but we must look for it whenever we have omphaloceles. Now, about gastroschisis also, we know that the outcome is good, and we have reports that you will see in the later talks that we have good outcome. But at times in a case like this, which seems to be similar to the earlier one, but again, the limb was not visualized very clearly, and the baby had limb body wall complex. There was absent limb. So these things might be present, and that we can only diagnose antenatally, and we need a postnatal follow-up to really, say whether our diagnosis was correct or not. So coming to the hurdles that we have faced all through are that women come late. The diagnosis is missed, maybe because of quality of ultrasound, but more often in GI anomaly, because they are developed late and they are diagnosed late. And an MTP Act at the same time does not allow a termination beyond 20 weeks. So that is also one of the problems. And the couple generally are not able to afford the genetic tests, such as microarray that we want to be done. So the positives are that we have a joint pediatric surgery and fetal medicine counseling clinic at our place, in which around from last 4 or 5 years, we have been counseling together. And we are seeing around 30 cases. We even gave a thesis to our student, which was published just recently, in which we looked at satisfaction scales of a couple who came to us in the antenatal period. And we have a genetic lab with the support from DBT, which is in the nascent stage. But we will be able to do karyotype here, and so that patients can afford it and it can be done. And most of all, we have a very good team, with which we have a coordination with pediatric surgery and the whole obstetricians and the fetal medicine specialist. And so together we can. And so thank you everyone for patient hearing.
Thank you, Manisha, for your presentation. I always enjoy your presentation, as always. It is a pleasure to listen to you. Shilpi?
Yeah. So thank you, Manisha. It was a wonderful talk listening to you, as usual. we'll keep the questions for the till the end of the session, I think, Manisha, is that right?
Yes.
Yeah, so let me introduce Dr. Ashok Khurana. Dr. Khurana we all are aware of Dr. Khurana and his work and his academic activities. Sir doesn't need any introduction, but just to let the audience know about him, he had his MD from AIMS and has been trained in Denmark in ultrasound. He works in the ultrasound lab and is a professor from the School of Health Sciences in Croatia. He was the past president of Society of Fetal Medicine and is very, very actively involved in the academic activities. Thank you, sir, for being here, and it's a privilege to have you here. So the floor is yours.
Thank you, Poonam. Thank you indeed. It's a pleasure to be here this afternoon. And my thanks to the Association of Gynecologists and Obstetricians of Delhi to give me this chance to be here in this joint meeting. It's wonderful when the Fetal Medicine Subcommittee gets together with the pediatric surgeons. And it's nice to see the Delhi Association of Pediatric Surgeons coming together for this. And I am looking forward to a lot of interesting discussions this afternoon. I will get the ball rolling with the antenatal management with respect to the diagnosis and prognostication. There's two parts to these which are going on at the same time. There's the fetal abdominal wall defects and bowel atresia. And I'll see how much time we spend on each, because really fetal abdominal wall defects are individual conditions. Bowel atresia is something in common, but in the 15-minute marathon, I'll try and see what I can do about it. We'll take you through some of the conventional stuff and then some of the early diagnosis. And this one, which is a pentalogic trial, diagnosed as early as 9 weeks of gestation. But more of the conventional stuff first. And so what I will do is, because it's only 15 minutes, not a review article approach, but a working approach, few embryological considerations, then a working classification, some mathematics and some technology which we need to know so that we are all on the same page and can.
Dr. Khurana, we can't see your screen.
Oh, the screen disappeared? All right. I will stop share and I will share it again. Did the first slide come on, or even that didn't come on?
Nothing came.
None of the slides came on, no.
No.
All right. Bear with me for a minute. I will just reshare this screen and then see how this goes. And do let me know when it comes on.
Yeah, we can see it now.
And can you see the full screen?
Yeah, you can just expand it, yeah.
Yeah, is that now expanded? Are you seeing the whole screen?
Yes.
Ah, wonderful. Then I don't have to feel nervous anymore. So these were the images I was trying to show off at the beginning, because the rest is all everyday stuff. But I said, let me make some impressive images right from the beginning. So are you able to still see the screen and my pointer? Am I all okay?
Yes.
Yeah, wonderful. So we'll go through some mathematics and some technology, like I was saying, and the relevance of evaluating the cord insertion, over which I will spend a lot of time, because truly speaking, that is what sets the thinking process going. And then, of course, a few words, not a detail, like I said, review article thing on the diagnosis and prognostication of the spectrum in these conditions. And now we talk in terms of a first, second, and a third trimester, because some of these can be picked up very, very early, and some of these cannot be picked up right until much later. So we do understand that these defects can be physiological because there is a physiological herniation of the gut into the base of the umbilical cord as the embryo goes through 8, 9, and 10 weeks of pregnancy, which might even persist up to the 11th week. And any abnormal protrusion of contents through the abdominal wall is called an abdominal wall defect. They're abbreviated as AWDs by the younger generation. And I love learning these because, like I said, we need to be on the same page. We've learned already that the two common ones are the omphalocele and the gastroschisis. But you also have the congenital umbilical cord hernias, bladder exstrophy, which is quite different from cloacal exstrophy, as we will learn, the body stock anomaly, which is, of course, a lethal abnormality, Then we've excluded prune belly from this syndrome because truly speaking, it's not an abdominal wall defect primarily, but an involvement of the abdominal wall at a later stage. But we will talk about pentalogy contrail and abdominoschisis due to amniotic bands. And I'll try and make sense out of these kind of images that you keep seeing as graphics. The important thing is that a correct prenatal diagnosis of these anomalies with ultrasound is extremely important for patient management. And I'm sure my pediatric surgical colleagues will bear me out on this. But it is unfortunate that many of these are incorrectly or incompletely diagnosed. If you sit and look at things in a very simple sort of a way, if I'm able to see that the defect is to the right of the cord insertion. Now, what did this happen? Are you able to see me at all?
We can see the slide, but we've missed the slide that you were telling us about. So you've got to go back on the same slide.
I know, I'm just wondering how this is happening, but bear with me for a minute and I will try and see that. Are you picking me up at all at the moment?
It's static at the moment.
It's static, all right.
Right, so we're on the page 1, the introduction page.
So you can see the first of my slides, is it?
That's right, yeah.
And how about now?
You'll be back, we're back, thanks.
Wonderful, thank you. I think this is going to be a nervous evening for me. So like I was mentioning, sometimes it's simple. You notice that yes, the cord insertion is in the center, the herniation is to the right, and okay, it's a gastroschisis. The cord insertion is at the apex of the lesion, that's an omphalocele. And here you say, all right, there's ridiculously bizarre genitalia with a cleft running right through the center. And you know we're looking at a cloacal exstrophy. But sometimes it's not so straightforward. And yet the diagnosis and the differentiation between these is so important for prognosis. And it's also important to figure out the timing, place, and mode of delivery, as Dr. Parna would be telling you. And so if we are to give optimal outcomes, then we really have to be careful about handling this. It can be a challenge, but the first thing is that increasing awareness of the full spectrum really improves prenatal diagnosis and accuracy. And it depends also on how much you know and how much technology you have. So it's not just that if you have a transvaginal transducer with colored Doppler that you'd be able to figure out anatomy. You have to have a familiarity of how to use it. You have to realize that it's not just all about transvaginal scanning in the first trimester as it is over here, but a transabdominal scan that might actually give you better images. On the other hand, if you're not aware of the fact of the association between acidic loculi in an omphalocele, you'll start wondering whether this is an umbilical cord cyst or something else. And of course, if you don't look hard enough, then you'll end up labeling an omphalocele just by itself without realizing that this is actually syndromic. And if you look at the fist, you find a tightly closed fist, the thumb is on the inside, then come the 2 fingers, and then the little finger and the pointer are on the outside. And you know for sure that we're looking at a trisomy 18 with a hopeless prognosis. So if you have that knowledge and if you follow that protocol, you are going to be able to make an accurate diagnosis, and that's how it works. But the first step really that is fundamentally important is to figure out where is the umbilical cord going. And let's show this from a chart that's off the net. And the important thing is to realize that you have a differential diagnosis, which is very limited if you have a normal cord insertion. And if you have an abnormal cord insertion, then you have to look much harder. If you have a normal cord insertion and the defect is to the right of the cord insertion, that's a gastroschisis, and you can be reasonably sure of that. If you have a low defect below the cord insertion and there's no extruded bowel, then we're looking at a bladder exstrophy, and you look further down and you find the perineum is okay, then you know you're confined to a bladder exstrophy. If the cord insertion is poorly defined or is abnormal, then you start looking and seeing where is it related to the anticipated mid-abdomen. So if you have a low defect, including the cord insertion and a urinary bladder that does not fill and genital abnormalities, you know you're looking at a cloacal exstrophy. If you have a cord insertion on the membrane surrounding the defect, that's an omphalocele. And if you have an anterior abdominal wall defect high above and potentially involving the cord insertion also, then you start thinking of a pentalogic contrail, and then you go even higher and you try and look for the ectobia cordis. And of course, if you're not finding any proper anatomic distribution, then you choose between an amnioschisis and an amniotic band syndrome and a body stock anomaly, where you will actually find no free floating cord. That's the way I use this. And then I take this further and let's see where this chart gets me. So the simplest one, of course, is the defect to the right of the umbilical cord insertion and gastroschisis. If the defect is below, then I start looking for associated abnormalities. So if I find a spinal defect or an imperfect anus by virtue of the fact that I don't see the anus, or a bladder or a cloacal exstrophy, I know I'm looking at something within the OEIS complex. And if I find the elephant trunk appearance, I start thinking of a cloacal exstrophy. And if I find a low cord insertion, no extruded bowel, a bladder that doesn't fill, that's a bladder exstrophy. So then I know, yes, this is what I'm going to see. On the other hand, if I find that the defect is above the cord insertion, then again, I start searching for existing abnormalities and I try and define the components of the pentalogy of Cantrell. Sometimes you're lucky and you find all 5, and then the patient is really unlucky. Sometimes you find only some of the components, and then that becomes a part of the pentalogy of Cantrell, where you find 3 or 4 of the 5 defects. And of course, the classic one, which I've now mentioned already, so that even the postgraduates would have learned that by now, that you have an omphalocele when the cord inserts onto the defect. And if you have no definite pattern, you're looking at an amniotic band syndrome. And if you have an overall absent cord and you have any of the other associated abnormalities, then you start thinking in terms of a body stock anomaly or a limb body wall complex. Not that there is too much of a difference between this, but the body stock anomaly classically would mean that you almost see no cord. And in the limb body wall complex, you might see some cord, some floating parts, some not so floating parts. And you might have a predominantly abdominal presentation or predominantly cranial presentation. Moving on from this chart, we do realize that if you look at a text like this, it makes no sense. And therefore, I had put in such nice busy slides, or however busy they might have been, to make sure that you carry that sort of a message home. And then we come to the next point, which is embryology. And the good news is we don't need images like this from the books anymore, because now we have living embryology, which we learn from good old transvaginal ultrasound with 3D. So we do know that the embryo beyond 7 weeks and towards 8 weeks will show an L shape, and it will also show a bulge at the base of the cord, and that is the physiological herniation, which will persist at 8 and 9 and perhaps 10 weeks. Sometimes you can find it going on almost to about 11 plus weeks, and by 12 weeks it should have certainly gone away, and then you find a nice flat abdominal wall, which you can reconfirm with a 3D scanning. We used to think that 3D scanning is not a part of the Indian paraphernalia at all because it's so expensive, but we do understand now that 3D machines are even cheaper than some of our 2D machines, and therefore we now use this on a regular basis. Now, there are some mathematics that we do in the first trimester, and one of them is that we don't really label omphalocele until about 12 weeks, and we don't like to call them an omphalocele if they're about less than 10 millimeters at the base. They shouldn't contain any liver. And if you have any doubt about any of these considerations, such as this, then you say, okay, let me just review what's going on. Remember, there's a lot of normal anatomy involved. And if you do find that you have this kind of cord insertion here lower down, and then you start wondering, what is this? Wherever the cord insertion is, you will notice that that is always the caudal end of the embryo. And therefore, this end here would then qualify as the exencephaly, and this portion would then qualify as an abnormal lower end of the fetus. And that's important from a prognostic point of view. But for any doubt that you have at the 12-week scan, call them back in at 14 to 16 weeks, preferably earlier. 14 would be a better window, and try and confirm what is going on. The other part about embryology we should know is from a teratogenesis point of view, and that all this happens between the 6th and the 8th week of gestation. So depending on whether there's been an abnormally huge radiation exposure which the fetus has survived, or there's teratogenicity from drugs, or she's really terribly uncontrolled diabetes, then you can expect this to happen along with other malformations. And then, of course, depending on what gets involved, you will have the resultant abnormality. But the important thing really about embryology here is the timing of the problem. Gastroschisis, coming to that, I will only spend a minute on some of these. That of course you will find the bulge on the right side, and you might find dilated bowel, but if that dilatation disappears, then you start suspecting massive necrosis. And this is why we like to follow gastroschisis in the third trimester as well, even if you've diagnosed it in the second trimester, because then that can tell you, yes, it's a worse prognosis. Then we do understand that there's additional anomalies, among which the central nervous system and cardiac malformations are the most common. And then even if everything turns out all right, there's something you owe your patient the prognosis, which you need to say is the limitation of ultrasound. And that is that limb muscles might get replaced by fibrous and fatty tissue about which antenatal diagnosis will have no clue. And that's called amyoplasia and can be quite disastrous for these patients. A fetal demise is uncommon and is usually related to other anomalies. So the usual story, you have to look at other anomalies as well. But remember that none of this comes easy. You have to have the right technology, and a transabdominal scan might make you suspect that something is wrong with the wall. But if the fetus is in the right position, do go ahead with a transvaginal scan. If you have any doubt on how much of this is bowel and how much of this is cord, switch on color and see which is cord and which is bowel. Check the fetus to see which is right, which is left by looking at heart position, fetal position, and liver position, and you will have a diagnosis. The search for associated abnormalities is extremely important. And again, for this, we must understand that the kind of delineation of anatomy that we get from a transvaginal scan, particularly is a 6 to 12 megahertz transvaginal transducer, is far more and will give you much more information. And that you have to keep on looking till you're completely satisfied, because not infrequently we find that there is a spinal defect, and then the prognosis is related more to the spinal defect than to the actual gastroschisis, or you might find defects in other systems as well. Now, the search for cardiac anomalies has to be done as early as possible. And this must also be undertaken at the same time, because it completely changes the picture. So here, if we have an atrioventricular septal defect, then again, the prognosis of this gastroschisis changes completely, and then the patient has to be counseled quite differently. In terms of chromosomal abnormalities in gastroschisis, we don't find too much of an associated genetic association, and therefore, routinely, it's not recommended to do this. Although some people are now beginning to think that for any patient with any anomaly who is planning to carry on, it's wise to do a microarray. But truly speaking, honestly speaking, it does not contribute very much in gastroschisis. Moving to omphalocele, the defect size and sac can be quite variable. It's important for people who do imaging to realize that there is this 5 centimeter cutoff that some pediatric surgeons like, and therefore they divide it into major and minor. Other people think of omphalocele that contain more than 75% of the liver as a giant omphalocele. So it's nice to know what the pediatric surgeon is thinking and the language that they use, so that you can then be on the same page. Polyamniosis common ascites can occur, and I often use colored Doppler to confirm that the cord insertion is sitting on the lesion. For prognosis, if you have a thick NT, there's a very high incidence of cardiac defects. 75% of cases of omphalocele will have chromosomal associations as well as non-chromosomal congenital abnormalities, which can be syndromic. So you really have to be careful in excluding things and making sure you get the right thing. 25% of cases will be the group which is most commonly trisomy 18, but could also be trisomy 13, 21, tetrasomy 12p, and a number of duplications and deletions. And 10% are syndromic, notably Beckwith-Wiedemann and Miller-Diecker. And therefore, you have to realize that you might therefore need to stop not just at a microarray, but go beyond that and specifically look for these defects. Also, that 1 out of 5 will have other major malformations, which could then have a greater bearing on the prognosis, such as a cardiac, a CNS, or a urogenital malformation. And that the omphalocele, like I've already mentioned, might be a part of other abdominal wall defects, particularly cloacal exstrophy and the pentality of Cantrell. Omphaloceles We think of them as simple. Very often these days, the first trimester diagnosis, unless of course you're in the group that looks at patients that report late. But when you look at it in the first trimester, you need to look for one further clue. And that clue is this. The clue is that look at the direction in which this points. If the omphalocele is pointing more superiorly, then start thinking of a possibility of a pentalogy. And if it is pointing more inferiorly, start thinking in terms of something that will ultimately be part of an OEIS complex. And the central ones would be the ones pointing straight up are more likely. But you really have to watch the fetus in a supine position, kick it about a bit by pushing with the transducer, and then try and see what this relationship is. But it's an interesting relationship and very interesting to observe as you see these patients serially. Remember here again that this business of clearly demonstrating the cord is extremely important and cannot be underemphasized. There is a measurement that is there in the literature which talks about the ratio of the occipital, the omphalocele circumference versus the abdominal circumference ratio. And it's different for different trimesters of pregnancy and might dictate the type of closure. Some pediatric surgeons accept this and some of them don't accept this. I personally feel that to actually measure the omphalocele circumference sometimes can be quite tricky in the first trimester, but we do try. We use a technique called tomographic ultrasound imaging, which is a multi-slice 3D technique, and that might help you because you get serial scans in an axial plane that helps you to actually measure this, but I guess 2D would be equally good. Umbilical hernia is something we often forget as people in fetal medicine. The difference lies in the fact that an omphalocele is covered only by amniotic membrane, and the hernia, the congenital umbilical hernia, is covered by intact skin. And typically, beyond bowel, there's not much in an umbilical hernia. Bladder exstrophy, quite the disastrous condition. The hallmark of this is the so-called absent urinary bladder. It's really a bladder that does not fill, and therefore urine is released into the amniotic cavity. The bladder halves are everted, they're exposed, and then of course the wall becomes very rough because it's exposed actually to amniotic fluid. Genital abnormalities often occur in association with this, particularly epispadias in the male and a bifid clitoris and vaginal and uterine anomalies in the female. The realization that this condition exists is very, very important because you have to differentiate from cloacal exstrophy. And the difference lies in the fact that in cloacal exstrophy, bowel segments are never extruded and the rectum is normally formed in bladder exstrophy. So cloacal exstrophy will show extrusion of bowel loops and an abnormal rectum, and that is a very classical sign. To get these sometimes on an ultrasound is tricky. You can try 3D and it actually works, but you have to be patient and get this in the right position. These are not my images, but I put them there just because this is the classical one described in the literature. What we more often actually see is non-recognizable divided genitalia and the big hypertrophied bladder wall on top of it. Remember that this degree of roughness or hypertrophy will only be seen late in pregnancy and not immediately. There is, of course, this doubt on the PCP and DT Act talking about sex determination. We in Southeast District of Delhi are very lucky, and people do understand this in our district. The officers there in our district, but the others may not so understand. So please be sensitive to the fact that yes, not everyone is equally educated. Sometimes when you don't see a bladder, you get very stuck. And there is this sign that's been recently described from India. It's called the K angle. And this is the normal angle that exists between the aorta and the umbilical artery branches. And if you have a wide K angle, then that says, okay, if it goes obtuse rather than an acute angle like this, you start thinking in terms of a bladder exstrophy. We're waiting for a larger validation study, but it's a really interesting sign to actually go through. We've already heard Dr. Manisha refer to the OEIS complex, and remember that it might be only a part of the OEIS complex that you see. So you don't always see the omphalocele. You might see omphalocele plus bladder exstrophy or all four, and sometimes just an imperfect anus and spinal defects. So do be aware that you don't see the whole thing. We've already discussed cloacal exstrophy, so I won't spend more time on it, except to tell you that yes, do be aware of the fact that it's a very extensive abnormality. You have to be patient to make sure that you are displaying it, and look out for other abnormalities of the Mullerian system as well. MRI can be useful sometimes, but I find it quite tricky because most of our radiologist friends are not so excited about fetal MRI, and we seem to get more information from a patient ultrasound examination, and particularly in 3D, and therefore we use more of that. Remember that sex assignment or reassignment can be challenging, and sometimes it's worth it doing 8-term amnio for fetal sexing, because you have to announce this, and doing it post-delivery can take quite some time. The body stock anomaly is a situation where you do see a fetus, but it's in a fixed position and you don't actually see a cord, and that's the usual thing. Sometimes you see the rest of the fetus because it's only fixed in one part, and sometimes it's more severe, and then you realize that you can only see it very close to the placental surface. You switch on color and you realize that, truly speaking, there is no cord, and there's a large portion of the fetus lying quite outside the amnion, and that gives you the clue that that's a body stock anomaly. For pentalogy, like I've already mentioned, you look for extension above the cord insertion. You try and see whether it's a partial or a complete. The prognosis is uniformly poor, and there's lots of other associated abnormalities, and the spine can be quite grotesque. When you see something like this, again, start looking for limbs carefully, because this might actually be part of a sirenomelia, and therefore you need to be, again, open-minded on all of this. Amnioschisis is something that is not so common, but can be seen, and then you find an abdominal wall that gets destroyed secondarily from bands that just don't move away. 2 slides more, if I may take 2 minutes more. Bowel atresias is the next topic, and here at least we have some flow which is common. When we talk about bowel, we realize that the images are quite different for duodenal atresia, and so is the prognosis. Similarly for jejunal, and similarly for ileal. But do remember that the sign of these conditions is dilated bowel, which may not be only because of the atresias. It could be because of a volvulus, a meconium event, sprung disease, megacystis, microcolon hyperperistalsis syndrome, chloride diarrheas, congenital bands, anomalous course of vessels, or not a true atresia, but a diaphragm or membrane within the bowel lumen. And that, again, which should open your mind that, look, atresia means that it's all absent. That's not necessarily so. It's a late second trimester or a third trimester finding. You find dilated stomach and bowel in duodenal atresia, but you really have to be careful to show that that's in communication, because sometimes you can have a fluid-filled stomach and an associated abdominal cyst. Here, with time, you see that there's a good communication, so you know you're looking at a duodenal atresia. Polyamnios is dependent on how high the abnormality is, and the higher the abnormality, the greater the amount of polyamnios. You can differentiate jejunal atresias from ileal atresias, because ileal atresias will show many more dilated loops, unless, of course, it's a multi-segment ileal atresia. And sometimes some workers believe that they can differentiate between the fold pattern and the jejunum and ileum. I find that a little tricky. Yes, you do find the valvulae conniventes a little more prominent in the jejunum and not so in the ileum, but that's not always so. There would be associated findings in some patients depending on the cause of the atresia. So you might find calcification in particulate ascites. You might find part of a genetic syndrome, such as in duodenal atresia. You often find other signs of trisomy 21. And of course, findings with other malformations and syndromic clusters. There are some norms for bowel dilatation, and the latest one came out a couple of years ago, and you can use this. I just like to be subjective about it rather than objective, but I know some workers love data. I've already overshot my time. Let me summarize that the cord insertion onto the anterior abdominal wall with color Doppler is a great sign to go by. Always look at urinary bladder with the umbilical arteries, do a complete anatomical survey, use technology liberally, use genetics liberally, because you need to use it particularly for the omphalocele, and teamwork is the answer to all of this. And thank you so much for your attention. Dr. Manisha was very kind in sanctioning me with 5 more minutes last night, so I added this little bit. Thank you indeed.
Thank you, Dr. Khurana, sir. It was indeed an enthralling lecture, and you are indeed a prodigious teacher. We are indeed lucky to have been attending this lecture of yours. I now invite Dr. Aparna. She definitely needs no introduction. She's one of the finest persons, the most sparkling, vivacious, magnetic persons, and a very dear friend. I invite Dr. Aparna to take us through the obstetric part of these abdominal wall defects.
So, a very good evening to all of you, and thank you, Dr. Reema, for those really wonderful words. First of all, thank you, Manju Puri ma'am. Thank you, Dr. Manisha and Shilpi for this very focused program. I mean, it's really, I think, one of a kind that we have started in the gynae circles. I think this is something that we need to look forward more to. And I must really congratulate Dr. Manisha. You have got an amazing collection of cases of, 200 plus abdominal malformations which have followed really good work. And I think we're going to sure see it as publication very soon. And thank you, Khurana sir, for that, elaborate, teaching. So it really helped us a lot. So I would say that we're going to talk about care around delivery and what the obstetricians must know. So when we talk about the quality care in abdominal malformations during pregnancy, after diagnosis. So I think this is the part where I would be talking about after diagnosis and during pregnancy and delivery. So I have taken the liberty of just adding the bit about antenatal follow-up, because that is something which was not being covered anywhere in of the topics. So which abdominal lesions, I would really stick to omphalocele, gastroschisis, and bowel atresia, because as sir has already said and mentioned that most of the other ones are really lethal and really not worth going ahead and discussing antenatal management and follow-up. The factors which actually determine the perinatal outcome, it is post-diagnostic fetal evaluation after we've made a diagnosis, parental counseling, how the parents accept this malformation, fetal follow-up, location, timing, and mode of delivery. I think these are very, very important things that need to be considered when we are counseling our patients. Now, I'll just, the first thing that I want to talk about is omphalocele. So what is the post-diagnostic fetal evaluation? As I was already mentioned, this is something which is associated with genetic issues, so a microarray. So I think this is one thing that we need to remember. Any malformation, we need to think beyond karyotype and a microarray and a syndromic testing if it is suggestive. Along with the fetal echocardiography, because obviously there are fetal cardiac malformations which are associated with it. Parental counseling should be done after a multidisciplinary team management discussion has happened. And what really happens is that the neonatal morbidity, mortality directly correlate with the presence and severity of associated malformations. So if there is associated pulmonary hyperplasia or associated triploidy, then definitely the prognosis is not going to be very good, and postnatal course is difficult to predict. So these are the points when we actually want to counsel parents. And what are the poor prognostic factors? A liver which is outside, absolutely large defect, ratio of the defect diameter to the widest diameter of the abdominal wall, and additional congenital malformations which will tell us that, okay, this baby might not do very well. And when we are doing a detailed ultrasound and we think that it is actually an isolated abnormality, but after delivery, we find that, okay, this is not an isolated, there's a large proportion of babies in which there could be cardiac anomaly, other abnormalities, syndromes, and other diagnoses actually. So this is something that will again change the prognosis of the baby. So what really happens in a big series of patients, it was seen 1,500 patients, infants with omphalocele, only 60% delivered a term and the rest had a preterm delivery, along with survival, which was 82% to hospital discharge. And the risk of infant death was 45% in patients with pulmonary hypertension. So, you get an idea of how the outcome is going to be. And these numbers are really important when we counsel the patient, because we have seen that, some numbers, some idea gives a definitive objective counseling to the patient. So after diagnosis, the patient is beyond the period for termination, patient is willing to continue pregnancy. We have to monitor every 3 to 4 weekly for fetal growth. And most importantly, the abdominal circumference has to be taken differently in a case with abdominal lesions. And there are certain formulas which are given by Seymour et al., who've looked into BPD, occipitofrontal, and femur length to calculate the fetal weight, which would give you a better estimation of fetal weight. Then, of course, you have to do the NST and biophysical profile, which should be started weekly from 32 weeks of gestation. And if the baby has growth restriction, oligohydramnios, or other problems, then you might need to do it more frequently. Where should you deliver these babies? Planning for delivery at a tertiary care center. Why? Because it has been seen that the baby delivers outside and brought in, transported, there are problems related to temperature, hydration, and initial care of the defect, and vascular compromise during transportation. So as you say, as we call it, in utero transfer of the babies to a place where you plan to deliver is always better than outborn babies. Now, the big thing about timing. If there are no other standard indications for early delivery, we need to manage them expectantly till spontaneous onset, or at least 39 weeks. Repeatedly, it has been seen by various studies that preterm birth offers no advantage. And in fact, in one of the biggest series of prenatally diagnosed isolated omphalocele, neonatal deaths actually occurred because of complications of prematurity. So even though we know that, the baby is malformed, or maybe even in gastroschisis, we'll talk about it later, that there is no role of any preterm delivery. Other indications definitely would be non-reassuring fetal heart or fetal growth restriction, which would require an indication for delivery on its own. Now, this is again the biggest question, how to deliver this, vaginal versus cesarean section. So there are no RCTs evaluating the optimum route. In most patients, vaginal is acceptable. No strong evidence that cesarean delivery would improve outcome. But if there is a giant omphalocele, which already was mentioned by Sir, if it is more than 75% of the liver is outside and a defect which is greater than 5 centimeters, then in that situation, you might want to do cesarean section to avoid the rupture, infection, and hemorrhage. And if you're planning a scheduled delivery, it is to be done at more than 39 weeks. And this systematic review actually showed that cesarean delivery had no effect on the only had effect on the likelihood of primary repair, but no improvement in the in neonatal sepsis or time till enteral feeding or length of hospital stay. Now, that is the most important thing for as obstetricians, that you are faced with a situation, you have to manage the baby initially. So what are the steps to be taken? Number one is delayed cord clamping, because even little bit more of volume that you are providing to the baby is going to help the baby in the long run. Next is, when you're clamping the cord, please be careful on where you are clamping. Avoid clamping the umbilical sac, because we know that it can contain bowel. After the delivery of the omphalocele, the bowel is wrapped in a sterile wrapping, and an orogastric tube is put to decompress the stomach and stabilize the airway, establish the IV axis, and positioning on the left side down and right side up if the blood pressure is low with tachycardia and the bowel which is appearing having a vascular compromise. So within the delivery room, one of the approach is to place gauze dressing soaked in warm sterile saline. We are doing cesarean section, so immediately what we can do is, gauze dressings to be put over the soaked in warm sterile saline, and cover the dressing with a clear plastic wrap. And some actually use a plastic bag that encloses the infant up to the chest. What needs to be avoided is excessively wet and circumferential dressings, which can macerate the omphalocele sac. Circumferential abdominal wraps should also be avoided, as they compromise the blood flow. So like in this particular case here, the baby is being delivered, and after the delivery and a delayed cord clamping, we have to be very careful on where we are clamping the cord and before we shorten the cord. So the baby has been delivered, and after shortening the cord, we have to be very careful, as the bowel loops can be there within the sac. And after that, it is something like a bag which is there, a plastic bag which is used to cover the baby from below upwards. And this bag is actually there. It can, prevent it provides good temperature, a thermoneutral atmosphere. It protects the omphalocele also. So the baby is wrapped in a bag. So various centers follow different protocols, but this can be one of the methods to manage the baby around delivery by a cesarean section when you're doing, or even after a normal delivery. So, and then this is a simulator setting in which the baby has been wrapped in the bag, an OG tube has been put, IV lines have been fixed, monitors have been fixed. So immediately after delivery, these are the things that we need to remember. IV fluids, antibiotics, a thorough physical examination, and maintain the thermoneutral atmosphere. Now, quickly going on to gastroschisis, more or less the care around delivery remains the same. The difference from gastroschisis between omphalocele and gastroschisis has been already elaborated. But what are the antenatal factors which affect prognosis in a gastroschisis? Here there is no membrane around the bowel, so there is leakage of valuable proteins resulting in poor growth. There is meconium stained liquor, and also the bowel is exteriorized into the amniotic fluid. So visible bowel dilatation more than 6 millimeter is again an important marker for prognosis. There is associated abnormality. Could be cardiac, gastric, gastrointestinal, or other organ system. Regarding pregnancy management, genetic studies, it is not increased above the baseline population in gastroschisis as in omphalocele, but we need to look for extraintestinal abnormalities, in which case amniocentesis and microarray needs to be done. Fetal monitoring starting 24 weeks, repeat every 3 to 4 weeks. And growth restriction is predictive of adverse pregnancy outcome and may be associated with increased risk of fetal demise. Liker abnormalities are more common because oligohydramnios because of fetal growth restriction or cord compression, and polyhydramnios because of bowel atresia and it is predictive of severe bowel complication. So fetal bowel assessment is very, very important. And if it is more than 25 millimeter dilated and acute changes like thickening, marker for prognosis. So weekly antepartum surveillance promptly rather than waiting till 32 weeks, there is substantial bowel dilatation. And adverse perinatal sequelae is related to umbilical cord compression and severe uteroplacental insufficiency. So fetal surveillance normally should begin by 32 weeks as there is increased risk of late fetal demise. And if there is substantial fetal bowel dilatation, then start the fetal surveillance as soon as you detect the problem. Delivery, it is much similar to omphalocele in a facility with appropriate resources, and inborn newborns have better outcome because of a better coordination. Timing, again, based on gestational age and ultrasound findings. It is seen that, in most of the cases with gastroschisis, the mean POG at delivery is around 36 weeks, mean POG of onset of labor. But everything has to be in consultation with a multidisciplinary team. And in a fetus with gastroschisis who has normal growth, normal amniotic fluid volume, and reassuring fetal testing, schedule the delivery at 38 weeks so that the late fetal deaths and stillbirths are avoided. So around 38 weeks is a good time to deliver gastroschisis. There have been proponents of even early delivery saying that, there is excessive exposure of the bowel to the amniotic fluid, but there is no evidence that planned preterm delivery can improve survival. So delivery at 38 weeks is a good option. Route, again, cesarean delivery for usual indications. Labor and rupture of membranes do not adversely affect outcome, and no evidence that cesarean improves outcome in uncomplicated gastroschisis. Some pediatric surgeons say that if there is liver involvement, then you can go for a cesarean section. And if there is liver herniation, you need to rule out the other complicated abdominal wall defects so that, it is not, you don't do a cesarean section for lethal malformation. Intrapartum fetal heart monitoring is very important because fetal heart rate abnormalities can be seen. Again, post-delivery, we need to examine the baby for problems and again put a gauze dressing and cover it. Some use again a plastic bag. Similar to the others, intravenous fluid, broad spectrum antibiotic. The risk to the fetus is very high because neonatal fluid losses are very high due to insensible heat and fluid room. Initial approach is wrapping the bowel, it's sterile saline, and infant is immediately placed in the plastic bag. And the additional measures are to stabilize the baby with IV fluid, antibiotics, and a patent airway. So this is all about gastroschisis and omphalocele. Just a few last words about bowel atresia. So this, again, why prenatal diagnosis? It does not really improve the outcome too much, but it can provide an opportunity for parental counseling, preparation, screening for associated anomalies, and option for pregnancy termination. So we need to have general principles at the first visit, do a complete anatomic survey along with fetal echo and amniocentesis. Every 2 to 3 weeks, look for any change in the appearance with bowel dilatation, ascites or cyst formation, and an interval fetal growth, and also assess for polyhydramnios because that's a risk for preterm delivery. General principles as per the mode of delivery should be as per standard obstetric indication, and it is again not an indication for cesarean delivery. The place should be at a center with appropriate level of neonatal support, pediatric surgery, and in utero transfer for such a patient is preferred. So I think I exceeded a few minutes, so I would apologize for that. But I think those are the principles that I would like to, how I would like to manage antenatal and intrapartum omphalocele gastroschisis or any other abdominal wall defect. Thank you so much.
Thank you, Dr. Aparna, for that lecture and really a great insight into how to manage abdominal wall defects. Thank you so much.
Hello, good afternoon, one. Actually, ma'am, we have one question in the chat box. Can I ask?
Yes.
Yeah. Dr. Shivangi want to ask, how should we counsel the patient if she came in the 3rd trimester with the omphalocele?
So, sir, should I take or you would?
Yeah,
like
go ahead. Go ahead. Yeah.
So as we discussed just now, and I think this is a very common scenario that the patients are coming to us late and they're diagnosed late. So first of all, we need to understand what is the degree of omphalocele. Is there associated anomalies or not? So that, because that would determine the prognosis. So is the liver is there, the associated anomalies are there. So, and also, you know, understanding this, that in the 3rd trimester, prenatal genetic testing is either not feasible or will not really change your management. So now that the patient is in the 3rd trimester, we need to tell about the problem of omphalocele, that the baby is going to require a surgical repair. Also that we cannot really rule out associated malformations at this stage. I mean, we can, but not associated genetic background at this stage. Given all of this, we can offer her a good antenatal and an intrapartum care so that the baby can be, you know, have an optimal outcome after that. The counseling should include the risks which are associated with omphalocele, the risks which are associated with a genetic abnormality associated, and the risks which are associated with associated structural malformation. We counsel for all of these, follow up these patients antenatally, provide an intranatal care, and hope for the best.
And if you feel that this patient is going to do something illegal, such as go in for a termination elsewhere, then it would be wise to get that sense and tell them that, look, maybe we should do an amniocentesis for you before you do that, because otherwise they'll be lost to follow up and we'll never know whether it had a genetic basis or not. So you have to size up your patient accordingly, get to their level, discuss things very openly and tell them, don't lose genetic follow-up in case you're going to terminate this illegally. Theoretically speaking, we have got permissions from courts in India for terminations even at 30 and 31 weeks of pregnancy if there was an associated genetic abnormality. So because we've got that from certain centers, I think it's worth it to perhaps discuss this a little more openly with the patient. Because otherwise we'll have no clue for their future reproductive concerns.
Yes, thank you, sir. So thanks to the chairpersons for spending their precious time with us, and thanks to the speakers for their excellent and the informative lectures. Now we are moving on our next session, which is on the postnatal management of the fetal abdominal wall malformations and the bowel atresia. For this, I would like to invite chairpersons. Okay. I would like to invite Dr. S Roy Choudhary, sir. Sir is a director professor and the former HOD of the Pediatric Surgery Department, and past president Delhi IAPS, fellow lecturer in the Pediatric Surgery, University of the Missouri, Kansas City, USA, and he has 102 scientific publications, authored a book of pediatric surgery, and he has been invited to present at numerous conferences and the CME, and also received 12 awards and college gold medal for the proficiency in the surgery, countess of the Ronald Shea medal in the clinical surgery, Research Day Awards Children's Mercy Hospital, Kansas City, USA. And sir is a editorial member and the reviewer of the many journals of the pediatric surgery, almost 12. Sir, we welcome to you. Next, I would like to invite Dr. Yogesh Kumar Sarin, sir. Sir is a director, professor, and head of the Department of the Pediatric Surgery in Lady Hardinge Medical College. And he is president-elect, Indian Association of the Pediatric Surgeons. Sir is the executive member of Indian Child Abuse, Neglect, and the Child Labor, and also executive member in Delhi chapter of Indian Academy of Pediatrics, former MS LNGP Hospital, and the officiating dean at the Maulana Azad Medical College. He has been written more than 300 articles and more than 30 chapters and one book also. Patron and emeritus editor in the Chief Journal Neonatal Surgery, and his fellowships are traumatology from Australia, laparoscopy UK, and the pediatric surgical oncology USA. Welcome, sir. Next, I would like to invite Dr. Anju Gambhir, ma'am. Ma'am is a senior consultant in the pediatric surgery at the Fortis Shalimar Bagh, Maharaja Agrasen Punjabi Bagh, Action Balaji, Paschim Vihar, and the Saroj Super Speciality Hospital, Rohini. And she's the secretary of the Delhi Association of Pediatric Surgeons. She has a special interest in the birth defects. Ma'am also conducted a workshop on the perinatal evaluation and the management of the birth defects with the NNF in December 2018. And she presented her papers in the international conferences of the birth defects and the Bratislava in Slovakia in the September 2019. And ma'am is also working to get insurance cover for the birth defects. So I request the chairpersons kindly introduce our speakers.
Sarin, would you introduce the first speaker, Professor Yogesh Sarin?
I think, sorry.
Please unmute yourself. Please unmute yourself.
Roy Choudhary, please go ahead with introductions.
So our first speaker for this session is Professor Udo Rowley. Professor Rowley, please, would you load your first slide? So Professor Rowley is Professor and Surgeon-in-Chief, President of German Association of Pediatric Surgery, Secretary General of UFAPS, and Secretary Treasurer of UEMS, Chairman of UPSA Scientific Committee. He had more than 130 publications and 20 book chapters. So he's going to tell us about management, postnatal management on abdominal malformations. To Professor Rowley, please.
Thank you very much. Good afternoon to you, prestigious colleagues. It's an honor for me to speak on this very well attended and organized session on abdominal wall defects. Just one thing I'd like to mention is FIH means this is the Hockey World Federation, and I'd like to tell you that because I know in India there's a passion for hockey. And I am a consultant, medical consultant for the World Hockey Association beside my professional obligations in pediatric surgery. Today, I was invited to talk about postnatal management of abdominal wall defects. And I'd like to take you through this. In today's session, I speak about major abdominal wall defects, mainly, of course, on gastroschisis and cloacal exstrophy and omphalocele. In high-income countries, as in ours, the survival of these patients has dramatically improved. We see as mortality, depending on the nature of the disease, between 2 and 15%. We now put actually our focus on the long-term outcome of these affected babies. And the postnatal management, as you already mentioned, has to be as a multidisciplinary approach being provided in the NICU and pediatric surgery. We have listened to very nice talks already about prenatal diagnosis. That's why I can make this very short. What we have in our environment, we have a high detection rate of both omphalocele and gastroschisis, and both of these prenatal detections have an influence on the postnatal course. So we know, and we have already mentioned this in your beautiful talks, that there's an overall high incidence of stillbirth in omphalocele. There is a large group which has associated malformation. Up to 50% presents with chromosomal abnormalities, and the decision making is the same in your country as in ours. We have to decide if there is a indication for termination of pregnancy. Usually, the pregnant ladies with an omphalocele baby will be referred to a tertiary center for delivery, and we have to decide on timing and mode of delivery, as we already have heard from you. And usually it will be a scheduled delivery. In gastroschisis, here we have a high detection rate, and about dilatation more than 10 millimeters after 30 weeks of gestation is a sign for secondary atresia, or actually volvulus, which you have already mentioned as well. And if we have a polyhydramnion, then we have a suspicion for atresia. The same as an omphalocele applies to gastroschisis. The prenatal diagnosis will influence the decision making. And I'm not sure, because there is no really data on this, there's presumably a high rate of termination of pregnancy of gastroschisis also in Germany. The overall mortality of omphalocele is almost 35% if we count all the termination cases and stillbirth into this group. And if the babies are getting to be delivered, and about 15% of mortality remains. This is, as you already have mentioned, depending on associated malformation, trisomy 13 or 18. The size of the defect is questionable, but we know that lung hypoplasia plays a major role in mortality. Mortality in gastroschisis is much lower in Germany, despite the fact that we don't know how high the rate of terminations is, but usually after delivery and after surgical treatment, up to 5% of babies will die, and this depends usually on secondary intestinal morbidity, NEC, or short bowel syndrome. These are some data from our county, and here you can see that in this selected group, we have a mortality in gastroschisis of less than 2% and an omphalocele of 24%, which is quite well known. And these are an overview of some cases we have sampled at the German Insurance Association, and here you can see the gastroschisis have about a mortality of 4%, and omphalocele almost 60%. We heard about perinatal considerations. So in Germany, usually the pregnant woman will be referred to a tertiary center. The baby will stay in utero, and then they undergo evaluation of associated malformation, especially in omphalocele. And as we already spoke about, we try to assess the size of the defect to decide on the later treatment steps. There's a big discussion in Europe. What do we do for delivery, especially with the abdominal wall defect? Is it necessary to make a cesarean section, or can these babies be delivered by vaginal delivery? And you can see this is some sort of a tried consensus. In a minor defect, a vaginal delivery can be attempted. In a large defect, a cesarean section is recommended. And these are the typical images. If we have seen them already. This is a small omphalocele, which also only contains bowel. Here you can see a very large omphalocele where the whole liver has been is in the sac. And here you can see a rare case of this amniotic band associated with a large omphalocele. The postnatal management, there's usually a scheduled delivery. We try to really get this baby scheduled to have the best team available for the subsequent treatment. Usually omphalocele will be born at term. Most of these babies would not display cardiopulmonary problems. Of course, you have seen this already in the beautiful talk before. We put the babies in the same way. We put them in a plastic bag, as you can see here. Usually the surgery of omphalocele is not emergency. We will assess together with our NICU colleagues the babies for associated malformation. And the indication for surgery and the mode of treatment will be dependent on the size of the defect, associated anomalies, and ruptured omphalocele. As you could imagine, the ruptured omphalocele is more emergency treatment as the others. The surgical strategies, and this is interesting, there's not a real consensus. Some groups advocating primary surgery, some groups advocating in large omphaloceles conservative treatment, and there's always single stage versus multiple stage surgery, silo versus patch. There are some cases which have been reported with tissue expanders and vacuum-assisted closure. And what we always do, and we usually try to make a primary closure in all cases, but the only consensus is that in a defect less than 5 centimeters, the single stage primary closure is advised. Here you can see some images of babies with a defect larger than 5 centimeters, a giant omphalocele. And this baby here, as you have seen the image already, this baby has a associated diaphragmatic hernia. And of course, to treat this one, we had to do multi-stage. And here you can see the typical appearance post-operatively after placement of a silo bag. Conservative treatment, as I already said, is advocated in large omphalocele and in some countries where you have not a good access to high care. And this is an image provided from my colleague, Lofty John from Nigeria. Here you can see a typical aspect of a conservative treated omphalocele. The postnatal management in gastroschisis, as we've already heard, is not too much different from the omphalocele. Here also we talk about scheduled delivery in a referral center. We also have heard that we usually don't reach 38 weeks of gestation. Most of the babies will be born between 35 and 37 weeks of gestation. The classical gastroschisis patient might have gastrointestinal complications, usually not major other associated malformations. And again, the treatment is not an emergency, but an urgent treatment compared to omphalocele. And again, we have different methods ranging from primary surgery to placement of a silo bag, which could be already placed on the NICU, and the NICU ward reduction as introduced by our prestigious colleague, Adrian Bianchi. Here you can see some typical images, and here you can also see what makes the difference. In the middle image, you see a beautiful bowel, which is not thickened, which looks completely healthy. And this we can do with this primary closure. And here you can see about typically with matting, it's dilated, and this maybe is not possible to really repair in one stage. If one stage repair is not feasible, we either use a Schusterplasty like this or a patch, and this is the outcome after 2 years. Here are typical steps. you place the silo, and then in both sides, the silo will be reduced every day. And after 2 days, in this case, we were able to facilitate the primary closure, the secondary closure, sorry. At the end of this talk, I would like to present you 3 nice special cases. This baby was referred about 4 weeks ago to us from another hospital, and they said they have clamped the umbilicus and they're not sure what the black thing is. They have, of course, you already spoke about this. If you clamp the umbilicus and there is suspicion of a minor omphalocele or hernia to the cord, you have to be very careful. In this case, the clamp was, as you can see here, sitting on the small bowel. We have repaired this, of course, in the baby as well. The second special case is a preterm baby, 28 weeks of gestation. It's one of a twin, was born outside from our hospital, but was referred at 2 o'clock in the morning because they said we don't have any intensive care facilities. And we have received this patient. And at least in our experience, this is a very unusual case because I always ask my students if this is a ruptured omphalocele or atypical gastroschisis. And of course, it's a gastroschisis because the umbilical cord is intact. And the unusual thing, at least for us, is that the whole liver was protruded out of the defect. And you can see the abdominal cavity is extremely small. This baby underwent a multi-stage repair, but this baby revealed very, very complicated course because of prematurity, and eventually the baby died because of a massive intercerebral bleeding. In the last special case, this is extremely rare, at least in our environment. This is a cloacal extrophy with omphalocele. We expect about 15 babies of this kind in Germany per year. And that's why we have only 2 centers which will deal with this. And the pediatric surgeon amongst us know that this is a complicated multi-stage procedure to get this repaired. The outcome overall is, as I already said, up to 85% of omphalocele will survive, 95% of gastroschisis usually survive. This depends on the defect size and omphalocele and associated anomalies. And frequent complications are, which is not a surprise in these babies, could be nutritional, pulmonary. There's an influence of neurodevelopment, and we already also mentioned this. There is a difference in between inborns and outborn patients. This is one of our long-term follow-up studies. We looked at patients with a gastrointestinal malformation after 2 years with a structured test for psychomotoric and psychological abilities. And you can see we included gastroschisis, omphalocele babies, patients 2 years old, and these patients were almost the same in their development as the normal controls, and the only difference was in verbal abilities. This was somehow delayed in these patients, which is for us it's a good news, a good result, because verbal abilities you actually can train and promote, and all the other factors were the same between patients with major gastrointestinal malformation compared to healthy controls. To summarize, patients with abdominal wall defects are index diagnosis and patients for pediatric surgery. We have a high prenatal detection rate, but we also have a high rate of terminated pregnancies and stillbirth. We always refer these patients for scheduled delivery to tertiary referral centers and reach quite a high number of survivors. That's why now our focus lies in these patients on the long-term outcome, neurodevelopment, and possible prevention. I thank you very much.
Thank you, Professor Roy, for your wonderful, illustrious lecture covering this major subject of gastroschisis and omphalocele abdominal wall defect. And especially thanks for accepting to deliver this talk. And I know it is late night hours in Germany, but you are still awake and
no, Professor Choudhary, it's much easier. Here's midday. It's 1 p.m. It's perfect.
Okay.
Right. The sun is shining.
Okay, great. Sorry for that then. Because I saw one of your mails, you said it would be late.
Maybe I was wrong.
Right. So that, only one question I have is, you said that a lot of this fetuses undergo termination. So I would be interested to know what is the threshold amongst the parents in Germany to continue pregnancy vis-a-vis to undergo termination when you detect such an abdominal wall defect?
Thank you for this question. I think that there's, first of all, there's a difference. If it is an omphalocele, it's the same as you recommended in all your hospitals. We will go for amniocentesis and we will find out if there is a trisomy. And if there is a trisomy 13 or 18 and omphalocele and other malformation, actually we would recommend termination of pregnancy. In difference to this, in gastroschisis, I actually was not aware that there is some cases of termination ongoing in Germany. But I spoke to our obstetricians and they said some parents wish to have a termination of pregnancy, even if it's obviously maybe uncomplicated gastroschisis. And it's legal. It's a legal approach. So in the case of either gastroschisis or omphalocele, and if the parents have a wish to terminate the pregnancy, this would be performed in Germany.
Maybe we'll keep the questions for the end of the session, because the next presenter is Dr. Vikram Khanna. It gives me pleasure to introduce Dr. Khanna, who is an associate professor of pediatric surgery in the Lady Hardinge Medical College, Kalavati Saran Children's Hospital, and he has many scientific publications, CME lectures and awards, and he's a very young, energetic surgeon and currently interested in neonatal surgery and providing a lot of care. So let us hear from Professor Dr. Khanna about management of abdominal wall defects in babies after birth. Dr. Khanna, stage is to you.
Thank you, Dr. Choudhary, and a very good evening to all of you. Am I visible, sir? Are my slides
visible? Yeah, you are visible and audible.
At the outset, I would like to thank AGOD for giving me this opportunity to share my experience, our experience, department's experience in managing antenatally diagnosed abdominal wall defects. But before we discuss our results, let's have a look at the Indian scenario. Let's move out of Delhi and other metros, and let's have an overview of the rural India as well. Antenatal screening is less than readily available, and we have pregnant women walking in the labor room without even a bare minimum single antenatal scan. The access to NICU care and parenteral nutrition is at dismal 19 and 36%. Primary closure rates barely reach 58%. And added to the equation is the use of custom-made silos, which are plagued with the problem of detachment, suture rupture, continuous fluid loss, and sepsis, increasing the mortality to more than 75% as compared to less than 25% in the developed world. The data I am going to share is collected from our fetal medicine clinic from December 2016 till February 2021. We would be discussing two major abdominal wall defects, that is omphalocele and gastroschisis. We did not have any patient of pentology of Cantrell or cloacal extrophy. Out of the 21 patients with abdominal wall defects, 3 patients underwent medical termination of pregnancy. 18 live patients were delivered vaginally. 2 of the patients died in the preoperative period. 1 patient was with omphalocele and a large ventricular septal defect. Another patient was a gastroschisis patient, which was delivered outside. We operated 16 patients with abdominal wall defects, out of which 4 were minor omphalocele or the hernia of the cord, and 1 major omphalocele with a large sac was treated conservatively. Among the gastroschisis patients, all 11 patients were operated upon on day 1 of life. To summarize, out of 9 omphalocele patients, 3 patients underwent medical termination for associated multiple anomalies. 1 patient died before surgery. He had a large VSD, and 1 patient was managed with application of mercurochrome and spirit to induce epithelialization of the sac. And 4 patients with hernia of the cord underwent surgery on day 1 of life. Among the gastroschisis patients, 11 out of 12 were preterm and all were low birth weight. 1 patient who was delivered elsewhere died before surgery, and 11 patients were operated upon on day 1 of life. 2 of these patients had associated small bowel atresia, and 1 patient died in the post-op period who was on prolonged parenteral nutrition due to intestinal failure. And this is a picture of a patient with omphalocele minor, and we could easily close the defect, and this is the post-op picture. Now, this is a patient of gastroschisis, which complicated by small bowel atresia. We could achieve a skin closure and fashioned a stoma in the middle to be repaired in the second surgery. This is an outborn patient with gastroschisis, and we could not save this patient, and he died even before surgery. This is a picture of a patient with large omphalocele sac managed with mercurochrome application. Note the epithelialization of the sac, which happened later, followed by the stage closure at 2.5 years of age. Now, the most important question which stares at us was there any advantage in diagnosing these conditions antenatally? And if you walk with me for the next few slides, we will be able to answer this question. First and foremost, the combined counseling by obstetrician, neonatologist, and pediatric surgeon was very, very reassuring to the anxious patients, and it helped prognosticate the patient and explain a reasonable post-surgical outcome. 3 of the omphalocele patients who underwent medical termination, this avoided a severe post-delivery trauma to the parents. Also, antenatal diagnosis translated into improved survival. But how? It was our impression that gastroschisis patients, even the simpler one, who should actually have a better outcome than the omphalocele patients, were dying so much so that their overall survival was almost equal or even worse than the omphalocele patients. But now, with a tertiary hospital care delivery, prompt NICU care, prevention of hypothermia, prevention of dehydration, treating hypoglycemia, electrolyte abnormalities, treating sepsis, care of the exposed intestinal contents, prepping them for surgery, placing a nasogastric tube, a Foley's catheter, and rectal syringing to empty the bowel has made a world of a difference in improving the post-surgical outcome of these patients. And also, being proactive actually helped. An early intervention, as mentioned by Dr. Rowley, we were able to do a skin flap closure at the bedside of the patient when they were on ventilator in 3 of our patients. And we also changed our preferred surgical technique in gastroschisis patients, which I will elaborate further, which led to improved outcomes. Out of 11 gastroschisis patients, primary closure was only possible in 1 patient, and in 2 patients, silo was created followed by sheath closure. But these patients were plagued by problems of prolonged ventilation, prolonged parenteral nutrition, continuous fluid loss from the sac, daily reductions to be done, cutting through of the sutures, and ever-present danger of sepsis. So we started doing abdominal skin flap closures, which is the skin flap was raised craniocaudally from the costal margin to the inguinal ligament and literally till the flanks, and abdominal contents were placed within these skin flaps and the skin was closed over the abdominal contents without closing the sheath. It was successfully done in 8 of our patients. These included the 3 patients in whom bedside reduction of the contents were done. 2 patients with complex gastroschisis with atresia were also closed using this technique, and the atresia was repaired in the second surgery. None of our patients had abdominal compartment syndrome, and in 2 patients, staged closure for so created ventral hernia has also been done. This is a picture of a gastroschisis patient in whom silo was fashioned, followed by the sheath closure. And this patient has massive amount of bowel outside his abdominal cavity, but still we were able to get the skin flaps cover over the abdominal content. The skin might be looking pale in this picture, but these patients do settle rapidly than the other patients. So all in all, we operated 16 patients with abdominal wall defects and having a survival of about 94%. We lost 1 patient of gastroschisis due to intestinal failure. All these patients required prolonged parenteral nutrition, but to be noted is mean time to enteral feed for skin flap closure was only 17 days, which was shorter than the patients who underwent other type of closures, which was 28 days. And the mean length of hospital stay for patients with skin flap closure was 23 days as compared to 35 days for other patients. Thus, 10 out of 11, that is 91% of our operated antenatally diagnosed gastroschisis patients were alive and feeding well at discharge. With antenatal diagnosis and delivery at our hospital, we even begin to answer perpetual research questions like, is matting of bowel loop present at the time of birth in patients with gastroschisis, or does it develop later? We can now say it is present at the time of birth and it only worsens with time. Thus, ladies and gentlemen, I would like to conclude by saying that immediate management of the newborn delivered following antenatal diagnosis of the abdominal wall defect, prompt NICU care, and a skin flap closure in gastroschisis have led to improved outcomes in our series. Thank you so much. Thank you very much for your patient listening.
Thank you, Vikram, for keeping on time and still giving a picture of what's happening in our center with abdominal wall defects since we are doing this joint fetal clinic. Professor Roy Choudhary for comments, please.
I just want to add on to what Dr. Vikram has said. I mean, before this, the speaker didn't use the word simple vis-a-vis complex gastroschisis. I mean, that difference is very, very important. Simple gastroschisis means the bowel has no issues. But if the bowel has atresias, bowel has necrosis, bowel has midgut volvulus, then it is a complex or complicated gastroschisis in which the morbidity and mortality is much more. As regards the management of gastroschisis, I want to add just a couple of more things. Gastroschisis is again a large spectrum. Many pictures have been shown by Dr. Vikram, Dr. Udo. If there is a small gastroschisis, we probably can easily close that on the bedside by what has been popularized by Adrian Bianchi, my friend from UK. But if the large matted gastroschisis is there, as shown in one of the slides in Dr. Vikram's talk, then probably we need to still make an incision right from the xiphi sternum all the way to the pubis to try to put this matted bowel into the abdomen. It's very possible that once you've done the skin closure, which is now becoming more and more popular in developing countries, that the matting will go away, and probably you will need to go in again to do a surgery for bowel atresias, which probably cannot be, definitely said at that time when you're putting the bowel inside the into the abdomen. One word about omphalocele. Many patients in countries like India would come at the age of 10, 12 years, where the conservative management was used. So the most of the abdominal contents will be lying in a sac which is covered by the skin, and literally the child will be holding that with her or his hands and walking around all this life. Now this patient, if you want to take up this patient for closure now at this age, it's not going to be that easy, and probably this patient would need to be admitted in the ward for a long time. We would need to do some kind of pneumatic distension of the abdomen so as to eventually close it along using, of course, some kind of PTFE or silo or whatever. So these are the things which probably need to be talked about. And another thing which Dr. Khurana briefly mentioned was the vanishing gastroschisis. The defect on the right side of the umbilicus could be of any size. It could be 0.5 centimeter, or it could be about 2 or 4 centimeter. If the defect is very small and the bowel from which it's coming out eventually gets strangulated, and in fetus, that strangulated bowel may get necrosed, and with which it was showing up, said, let's say earlier weeks, now will not be showing up anymore. So that is also, it doesn't happen too often, but it could happen, and we should know of that entity as vanishing gastroschisis. Dr. Udo showed a slide towards the end about cloacal exostrophy, which could be simple or could be the entire spectrum of OIES. One thing which must be considered in a developing country like us is not to go for the complete repair in the very first stage. Many times what I've done is I have created a bladder exostrophy. So you are basically converting a cloacal exostrophy into a bladder exostrophy initially, but just repairing the mid part, which represents the bowel, and probably creating stoma or doing an anoplasty, and then leaving this abdominal wall defect as a bladder exostrophy and treating it later. Because if you attempt doing everything together, it probably becomes very difficult for us to have that kind of intensive care to save these patients. I don't remember saving many patients of cloacal exostrophy in Maulana Azad Medical College, where I was HOD for almost 21 years. These are the small contribution from my side.
I think you made some valuable comments, and I'm sure all pediatric surgeons will appreciate your comments very much. Since we do not have a very long time for discussion, we are limited by time. I hand over it to Professor Dr. Anju Gambhir to invite the next speaker.
Yeah, it's my pleasure to invite Professor Kokila Lakhu from Oxford, University of Oxford and University Hospitals. She is a full-time clinician over there in the UK, and she is the honorary professor in South Africa, Wits University, Tanzania, Muhimbili University. She has special interest, research interest in global surgery, NEC, congenital lung lesions, and she holds the position of lead for fetal and neonatal care, lead for global surgery in Oxford University, founder and past president of the Global Initiative for Children in Children's Surgery. She is the chair of the International Committee for the British Association of Pediatric Surgeons. And she has, to her credit, many publications, 3 books, over 83 chapters, and over 300 publications. I would like to add that it was my honor and privilege to have met Professor Kokila Lakhu way back in 2014 when I visited Oxford for around 3 weeks to be with her. and sample, of course, one of those days, have a lovely dinner with her along with Professor Gupta, a neonatologist in the Oxford University there. Professor Kokila, kindly begin your talk. Thank you.
Thank you very much for that kind introduction. And it is my great pleasure to be sharing the platform with so many talented people as well as the audience. I will kick off, and this has been mentioned. Just to give you a little bit of overview, this is one of the 4 hospitals of the Oxford University Hospitals. This is the acute hospital where we have the maternity and the children's sector in one site. So this is the entrance to the maternity unit, which Anju, you probably recognize, and you can see lots of cycles. So we get our patients on bicycles to come. So the pregnant women have to cycle, otherwise they can't get in. In terms of children, this is our children's hospital, and all the cycles are locked up behind those yellow windows because cycle theft is very high in Oxford. You might be surprised. What I've done is, because this is an interface between the fetal medicine specialists and surgeons, I've brought together my talk showing what the obstetricians would like to know postnatally what happens, and the pediatric surgeons would like to know what happens prenatally. And I have the privilege of running a fetal surgical clinic together with my obstetric colleagues, where we scan the patients together. So I get extremely well educated by my fetal medicine specialists as to what they're seeing on scans and what we can do. So over 20 years, I've developed some skills in that area, though I would never attempt to scan the patients on my own. So the current UK practice regarding fetal medicine is that 2 routine ultrasound scans, almost all the patients get scanned, almost 100%. So there's a 12 weeks scan that looks at some factors as mentioned on the slide, and then there's a 20 weeks anomaly scan. For those patients that are high risk, there's a 6-week scan as well. We do a fetal surgical clinic when the patients are around 24 to 30 weeks gestation, and this is a monthly clinic. So this is what happens in Oxford. There's a fetal medicine center, which my colleague Lawrence Impey and myself run on a monthly basis, but he's the head that does the actual running and the administration of that clinic. So there's cardiac clinics that take place on different days. There's genetic clinics, and there's a 20-week anomaly scan done. That bit is done by a radiographer. And then all of that gets fed into the fetal medicine clinic. We have a weekly meeting for difficult cases, and if there aren't any surgical ones, I don't need to attend that meeting. Our clinic team that comes to the fetal surgical clinic, which happens on a monthly basis, monthly multidisciplinary, and I am always scanning the patients. Mr. Impey is scanning the patients in my presence, and then we jointly counsel the patients. So the team in the clinic team are a surgeon, a specialty surgeon in case there's a cleft or a neurosurgical case, a fetal specialist, which is Mr. Impey, neonatologist, surgical nurse, and a midwife. What do we do at the clinic, and what is important that we get out of the clinic is that the information to prospective parents. What do they want to know? They want to know fetal outcomes, possible interventions, place, time, and route of delivery, surgical management, postnatal outcomes, and long-term outcomes. What has a surgeon in the presence in this fetal medicine clinic has influenced is that in our institution, we're able to revise the diagnosis 13% of the time. We had chose to terminate patients for complex abnormality in about 5%. About 50% the site of delivery is changed. And this is quite a false figure because all our district general hospitals, when they scan babies with surgical abnormalities, they routinely send them to us. So that is quite an inflated percentage. And then in 16% of the time, we changed the mode of delivery. And we published this in our publication in 2010. Moving to the structural abnormalities. So top and OA are tracheoesophageal fistula and esophageal atresia. Usually prenatally, it's suspected by absent gastric bubble, and with suspected polyhydramnios or with polyhydramnios, it becomes even more of a possibility. So without polyhydramnios, the sensitivity is 42%, but with it, it's about 56% in the world literature. In our institution, with the surgeon and obstetrician, the same surgeon and the same obstetrician working on a monthly basis, our figures have gone up to 72%. About 50% of these patients will have other abnormalities, which we look for, and the recurrence rate in future pregnancies is about 1%. The associated abnormalities are of the acronym VACTERL, or there's Chart syndrome, there might be duodenal atresia, and they are present in 50% of the cases. So on the slide, you can see some vertebral abnormalities, cardiac abnormalities in the postnatal stage, duodenal stenosis, and anorectal malformation. So in tracheoesophageal fistula and esophageal atresia, we have multiple varieties, but the most common one is the first one where you have an upper pouch and a distal fistula. The second common one is when you have an isolated atresia with no fistula. And the third one is a H-type fistula where there's a connection between the two. And these could be picked up later in postnatally. This is just to show you that when you have a esophageal atresia with the top, that's where you see that the nasogastric tube is not going further, and there is gas in the abdomen that denotes a distal fistula. When it's isolated, you see no gas in the bottom bit. And when there's a H-type fistula, you see contrast in the breathing pipe and the contrast in the esophageal area. How do we come to the diagnosis postnatally now? Is an increasing salivation in a baby, unable to pass a nasogastric tube. And then it is quite vital to do what I call a babygram, because you can identify the level of atresia. You can pick up if there's chest infections. You can look for vertebral and rib abnormalities. This patient's got 13 pairs of rib. And you can see whether the abdomen is gasless or not. So it will denote the type of fistula. How do we manage these postnatally? So the outcomes are very much dependent on your associated anomalies, the size of the baby, the weight of the baby, and the gap. We offer surgery. So in this slide, I've just shown you the normal type of upper pouch and distal fistula. This is when there's a wide gap. And this is when you need to think about replacement organ. So the surgery can be primarily be done on this one. You can have delayed with pouch care with a leplogal tube and a gastrostomy in this condition, which is the one on your right upper picture. And then for the right lower picture, a replacement organ. And then there are centers that would consider a video-assisted thoracoscopic approach. So for those in the obstetrics camp, you can see once we see this type of picture, intraoperatively, what you actually see is the distal fistula and the upper pouch anastomosed, and the upper pouch is always much thicker. And this is the azygous vein that has been divided. When you have an isolated esophageal atresia, then there are various ways of managing them. What we do in Oxford is that we do an upper pouch care and we do a gastrostomy on these babies. And at 6 weeks, we check for gap assessment. And in the picture on the left, the first one, you can see that the gap is pretty wide. At 9 weeks, with our gap assessment, you could see it's getting better. And we could have attempted a closure then, but we waited a few weeks longer, and that made it so much easier to do a primary repair. Sometimes with the wide gaps, it's not too big a gap, but it's just wide enough, not enough to do a primary anastomosis, but not enough to do a replacement organ. There are other modalities such as the Goff flap, which is an Oxford invention. where you do a flap on the upper thick pouch and do a lengthening procedure as shown there. Or you can do myotomies, and I have used myotomies, not frequently, but on several occasions, which has worked quite well in just giving me another 0.5 centimeters or 1 centimeters length. Sometimes I've done a double myotomy to give me just that little bit of leeway so that there isn't a tension in my anastomosis. Fokker, as many of the pediatric surgeons know, have described a technique where you put a suture in the upper pouch and you put a suture in the lower pouch, and then you pull them outside the body, and then over weeks, you kind of stretch them so that bringing the upper and lower pouches together. And then our German colleagues are even using magnets to see if esophagus can be pulled together for primary anastomosis. If there's no esophagus, like in this one, then you would consider replacement. And there are substitute organs. So about 2 to 5% of patients will require a substitution. Some centers use the jejunum, some centers use the colon, and many centers use the stomach. And a lot of us that were trained in South Africa have taken this technique worldwide, and we found this one of the better techniques. And in my hands, that is the best replacement organ. My personal experience is I do a right-sided esophagostomy and a gastrostomy. I try and attempt sham feeding, and then I perform the definitive pull-through after 3 months of age, depending on the size of the baby. So what I do is I reduce the stomach, and then I do a pyloroplasty. We used to do pyloromyotomies and realized that does cause obstructive problems, so I've shifted to pyloroplasties over the past 15 years. I do an isoperistaltic loop. I use the posterior mediastinum. And in the last 15 years, I've also been hitching the stomach to tissues around the clavicle to avoid anastomotic, to protect the anastomosis in the neck. And in that way, my stricture rate or leak rate that used to happen before, which we use conservative management to manage, have stopped. And I'll also do a feeding jejunostomy to give this patient enough time to start using the new esophagus. The results are really good in isolated ones, but in children that have that are premature, that have multiple abnormalities, that have respiratory problems, the feeding jejunostomy does help because they might take longer than about 6 weeks for feeding. So it's a really good protective mechanism. The future might be with tissue engineering. So what happens postnatally? Because the parents that you're counseling will want to know, okay, as surgeons, you can fix this problem, but what do I expect postnatally? So you can talk about leaks, you can talk about, and the leaks, a lot of them are managed conservatively because for any anastomosis, if you put a contrast through, you might feel a little bit of contrast leaking through. Stricture rate is about 50%, but many of them require just one dilatation. You talk about aspirations, you talk about recurrence, you talk about feeding difficulties because you do have motility problems in the upper part of the esophagus who's not talking to the lower part of the esophagus that you've joined. What are the long-term outcomes? About 50% of cases will be below the 25th centile for growth, but you need to reassure the families that they will be smaller in the class up to about 11, 12 years of age. And when puberty kicks in, they do normalize their growth, especially height, because boys are very conscious if they are shorter than girls in their class. And you just need to reassure the families that, there is the growth spurt that will happen later. 65% will have some sort of respiratory symptoms, and almost 60% will resolve in the first few months of life. 50% have some sort of gastroesophageal reflux. And as I said, the isolated group do better. The problems are mainly with associated abnormalities, the delayed repair, and those that require replacement organs. Moving on to lower down, duodenal atresia. So prenatally, the detection rate at 20 weeks gestation is low because this event tends to happen later on. The minute you see a double bubble, there's a 100% detection rate. So the key to diagnosing duodenal atresias are usually when the mother has polyhydramnios, then the fetal medicine unit deliberately look out for duodenal double bubble. About 50% will have associated anomalies, 30% have trisomies, 20% have cardiac, and then there's a vectoral element in them as well. And these are just the prenatal slides that shows double bubbles in different views, and one with diagnosis of trisomy 21 prenatally. So what are the types? So you can get one that has the continuity is interrupted by a complete web or a stenosis. The second one is where there's a fibrous tissue joining the upper part of the duodenum to the lower part. And then you can have one that has a gap. And I've got a picture there showing that sometimes the gap is due to an annular pancreas. When you have just a duodenal atresia, the type of intrinsic duodenal obstruction may be a complete membrane or a windsock where you've got a little hole in the membrane and it windsocks into the distal part of the duodenum, or you can have a stenotic element. So postnatal diagnoses are made with radiography, but clinically they have bile stain vomits, they have scaphoid abdomen, and they may be jaundice because the enterohepatic pathway is interrupted. The X-ray on the left side is one of the older pictures when babies were held up, so you can see air fluid levels. We don't do that anymore. And on the right side, you can see different views of duodenal atresia slides and the associated abnormalities we talked about. The differential diagnosis from malrotation is very important in a picture. So say you have a baby with bile stain vomiting and the postnatal picture shows you the one that's on the left-hand side. So you see a double bubble, but you also see some little bit of gas going through. And this is the bane of the pediatric surgeons, where the pediatric surgeon will be scratching their head. Is this duodenal atresia? Is this malrotation? Because this is time critical. If you think this is duodenal atresia, you can wait and do your surgery in the morning. If you think this is possibly a malrotation, you need to be in theater pretty quickly. And these are, the top picture shows you a duodenal atresia, a duodenal stenosis with a web. So there's some gas proximal and distal to the obstruction. The lower pictures is the malrotation, where you can see that the bowel has become malrotated with the illustrative picture on the left. So management postnatally is resuscitation, nasogastric tube replacement, and as I said, not urgent for surgery. What are the postnatal outcomes? So you can reassure the parents that survival is 95%. The mortality or morbidity in that 5% is usually due to associated abnormalities, and especially severe form of trisomy or severe complex cardiac abnormalities that result in mortality, prematurity, or low birth weight. Sometimes they'll have a delayed full enteral feeding, and in our setup, we put in long lines with TPN, but maybe in some of your setups, you put in tubes that go beyond the obstruction. Moving on to the last part of the bowel anomalies. Other abnormalities are bowel atresias and prenatally picked up, as you can see in the pictures on your right. Polyhydramnios and dilated bowel are key. The higher the obstruction, the delayed the feeding. There is one type, which is type 3, that can provide the morbidity or mortality in this particular condition, whereby there might be a volvulus and you'll have short bowel. And 10% of them might have a poor prognosis because of the type 3 with a volvulus and short bowel, or the type 4, where the bowel has just got so many sausages that you don't have viable bowel, because sometimes it's just a cord. Large bowel obstruction is less sensitive prenatally. What happens postnatally is, again, bowel stain vomiting, abdominal distension if it's low obstruction, and upper abdomen distension if it's a high obstruction, with or without meconium. This is the type of abnormalities for my obstetrics colleagues. So the type 1 that you see is a level of obstruction, but no gaps. And that you can see in the left-hand picture of the operative picture. Then type 2 is where the bowel is separated, but the mesentery is intact, which you can see in the middle picture at the bottom. And type 3B that I talked about, the one that has a dilated bowel. So what you see in that picture on the right-hand side is a single vessel, a bowel vessel, with the entire bowel a kind of Christmas tree or apple peeled around the superior mesenteric artery. And then the dilated loop of bowel on the right-hand side of the picture is the dilated intestine proximal to the obstruction. What do you see by imaging? If you look at the left picture, if the obstruction is high, you see fewer loops of bowel. If the obstruction is low, you see quite a large number of bowel loops. And this sometimes creates a differential diagnosis, because you might have this kind of picture in functional obstructions as well. So meconium plugs, Hirschsprung's disease might also give you a picture like that. So we have a routine contrast study done from the lowest abdomen as an enema, so that we can identify what type of lower obstruction this baby has. What do we do surgically? So once we found the atresia, if the gaps are not, or the discrepancy between the bowel is not a lot, we would just extend the narrower bowel a little bit further to create a fish mouth effect, so that we can anastomose that comfortably. If there's quite a dilated segment and a normal enough length of bowel, I tend to resect it. Or if I find that the bowel is pretty short and I need to save every bit of bowel, then I will reduce it using a stapling device and then oversew it with suture material. Also, another condition within kind of bowel is echogenic bowel. And when we see echogenic bowel in the Western countries, we always worry about cystic fibrosis. Some of the trisomy 21s have shown echogenic bowel. Is this a sign of early obstruction? In our paper, we showed that it didn't, and it doesn't show any long-term pathology. So the echogenic bowel, if you don't have cystic fibrosis or you don't have trisomy, it's just a spurious bit of meconium kind of shining through on the scan. It doesn't tell you that there's going to be some problems with the baby later on. So in conclusion, as a team of fetal medicine, multidisciplinary team, we need to understand the condition. We need to know the natural history. We need to understand the limitation of prenatal diagnosis, know that many conditions in pediatric surgery or structural abnormalities has associated abnormalities, what the interventional risks are if we can intervene prenatally, and what the postnatal outcomes are. There's quite a lot of I've written about it, and in the latest book that Puri has put out, I've written a chapter on this subject. And most of them have got the same information that I've put through. So thank you very much for your time and attention. And I feel inform parents in your MDTs without alarming them. Thank you very much for your time.
Thank you, Professor Lakhu, for such a lucid, informative talk on the subject, and also giving information at how to deal with the parents. And for the purpose of the information to the residents, I would just like to add, you mentioned that around 13% of the diagnosis are changed, reviewed postnatally. I'd just like to add, what I know is around 42% of those bowel GI malformations that are detected antenatally, only around 42% of those are confirmed in the postnatal period. This is for the, and about only 16% of those that are detected operated on postnatally have been detected antenatally. So though the radiologists, ultrasonologists are doing quite a good job, but I think there are still some areas that would take some time to get covered. Thank you once again. And thank you to the organizers and AOGD for having me on this lovely panel. Thank you.
Thank you. Next is by Dr. Amit. Professor Sarin to introduce Dr. Amit, please.
Dr. Amit, please share your screen.
Dr. Sarin, you have to unmute yourself, please.
Dr. Amit Gupta is Associate Professor of Pediatric Surgery in Department of Pediatric Surgery in Lady Harding Medical College and Kalavati Saran Hospital. And I've known him since he was doing his national board in pediatric surgery from Chennai. He's a young, energetic, bubbly fellow. Let's hear from him. Thank you so much.
Is my slide visible, sir? Am I audible and visible?
Yeah, you're audible and visible. Please go on.
Please go ahead.
Yeah, it's an honor for me to be allowed to present our experience with the perinatal findings of gastrointestinal obstruction by the organizers. The data which I am presenting is from December 2016 to November 2020. Perinatal obstructions were the in perinatal gastrointestinal obstruction. These were the third most common anomaly after CNS and renal anomalies, followed by abdominal wall defects. Now, duodenal atresia was the most common anomaly in these obstructions, followed by esophageal atresia, meconium peritonitis, and small bowel atresia in our series. The advantage of fetal clinic is it provides proper guidance regarding in utero transfer to a tertiary care center, where postnatally in-house timely intervention prevents the comorbidities due to delay in diagnosis. Over 4 years, we have seen around 40 cases of gastrointestinal obstruction, and the diagnostic accuracy of prenatal ultrasound was 82.5%, and we could detect only 17.5% of these anomalies before 20 weeks. The overall survival was around 50% in these anomalies. For duodenal atresia, it was slightly more than 50%, duodenal and esophageal atresia. Whereas in meconium peritonitis, there was a striking difference between intra-abdominal calcification, which was isolated. These patients, they had a good prognosis with 75%. Whereas fetal ascites, none of the babies survived. Regarding birth-related data, the 82% patients had vaginal delivery, 56.7% were preterm, and 66.7% babies were low birth weight. Male to female ratio is almost equal. Now, in final postnatal diagnosis, it differed in around 20% of cases, and 17.5% of these cases were normal. So in around out of 16 duodenal atresia, one had a postnatal normal study, and one turned out to be a proximal ideal atresia. In intra-abdominal calcifications, there were 4 such babies detected. Out of these 4, 3 had normal study. But in contrast, fetal ascites, babies with fetal ascites, there were 5 prenatal detection. Out of that, 2 were stillborn and 3 died pre-operatively. Whereas echogenic bowel and dilated bowel loops, 50% of these patients had a normal scan, And in one baby with dilated bowel loop who was followed till late infancy, he developed symptoms of Hirschsprung's disease. So in the postnatal period, we could follow 36 patients, and the overall survival for these patients, various group of patients was in duodenal atresia, it was 58.3%, esophageal atresia, it was 71.4%, small bowel atresia, 33.3%. In meconium peritonitis, we could operate only one patient, and that patient did not survive. And a Hirschsprung's disease, which was detected in late infancy during follow-up, that child is on colostomy now. Regarding mortality, the cardiac anomaly constituted around 1/3 of the cases as a cause for mortality, and in 1/3 cases they had intestinal failure, and around 2/3 of our cases had anastomotic leak as a cause of mortality. Although they had a few of them had other anomalies also. 4 patients died preoperatively. One small bowel atresia due to interrupted aortic arch, and other 3 were fetal ascites because of respiratory distress and refractory shock. We could not operate in any of the fetal ascites cases. So overall outcome of those babies whom we operated was around 61%. 61% patients survived. We noticed prematurity and low birth weight did not influence the outcome significantly due to our in-house level 4 NICU facility. There was no significant difference because of prematurity and low birth weight between the survivors and non-survivors. Around 62.5% of mortalities had associated malformations, and major cardiac anomaly accounted for around 50% of the mortalities. It was associated in 50% of the mortalities. Now coming to individual anomalies, duodenal atresia was the most common malformation. Median gestational age was around 36 weeks, 4 days, with birth of 2.2 kg. We operated on 12 patients. Out of them, 7 survived. And apparently we had a better survival rate for low birth weight babies, but then the number is very small. In post-surgical mortality, we found anastomotic leak in 3 patients and intestinal failure in 2 preterm babies. 2 out of 3 babies with anastomotic leak had malformations also. One had major cardiac anomaly and one had Down phenotype. We had 7 esophageal atresia, which was the second most common malformation, with median gestational age 34 weeks, median birth weight of 2.19 kg. Type A constituted 2 cases and type C 5 cases who were operated by us. The survival rate was 71.4%. Reason for mortality was anastomotic leak with associated cardiac anomaly in 2 patients. And we had only 3 patients with small bowel atresias with median birth weight 2.12 kgs. Median gestational age was 34 weeks. One died preoperatively due to cardiac anomaly, and the other, out of the other 2, one had an anastomotic leak and did not survive. One has survived. In cases where we had signs of meconium peritonitis, the cases with isolated intra-abdominal calcification detected prenatally, they had 75% survival rate, whereas the echogenic bowel and dilated bowel loops had 50%, and then in fetal ascites, none of the fetuses survived postnatally. So, and then this is it has been illustrated by Zangeri et al. In their paper, where any of the combinations with intra-abdominal calcification increases the chances of postnatal surgery. So such babies should be counseled, and they should be delivered in a tertiary care center. These are the pictures of a meconium peritonitis who we operated. Now, is there a further scope for improvement from our observations? Yes, we would like to improve our chances of anastomotic healing by giving a better post-operative intensive care, which may enhance perfusion and decrease chances of anastomotic dehiscence. Also, we will audit our surgical technique and suture materials used to prevent the apparently high rate of anastomotic leak, which we noticed in our cases. And also to decrease the adverse effect of congenital cardiac anomalies, we should like to have availability of dedicated pediatric cardiology and cardiothoracic surgery services at our center, which at present is not available. Thank you. Thank you for patient listening.
Amit, you can unshare your slide.
Yes, sir.
Stop sharing. Is there any comment? Professor Sareen, is he there? Shall we go on to the next? Professor Sareen, you are there, or shall we go on to the next talk?
No, I'm very much there, but I think we are really going much behind our schedule. I think
Yeah.
we should go on.
So I think since we are going behind schedule and still one more talk is left, although not the least one, but the speaker for the next talk, I have the pleasure to invite Dr. Shilpa Sharma. Dr. Shilpa, are you here?
Amit, can you please unshare your screen? Dr. Amit?
Dr. Amit, unshare your screen, please.
Is it still sharing, sir?
Yeah.
Yes. Meanwhile, let me have the pleasure to introduce Dr. Shilpa Sharma. She is currently working as additional professor of pediatric surgery in the prestigious All India Institute of Medical Science, New Delhi. And amongst her illustrious career, currently she is the president of Delhi Association of Pediatric Surgeons, and she's the office bearer and executive council member of World Federation Organization of Federation of Association of Pediatric Surgeons, executive committee member of Indian Association of Pediatric Surgeons, so many more affiliations. So without wasting much time, may I invite Dr. Sharma to deliver a talk on long-term outcomes.
Thank you so much, sir. I would like to thank Lady Harding team, both of gynecologists and pediatric surgeons, for this wonderful session. Those who are interested are there in this seminar. So everybody who looks after antenatal cases knows that you're looking after two human beings. So as much as the gynecologist get involved with the baby, we get involved with the mother. So I'll be speaking today about long-term outcome after repair of abdominal wall defects and bowel atresias. Today, in different parts of India, we do still witness factors like delayed referrals, lack of awareness, lack of diagnosis, hypothermia, and sepsis. On the other hand, we have been fortunate to adopt recent advances like antenatal diagnosis, neonatal ICUs, and parenteral nutrition, which have made a marked difference. The objectives would be to take you through the three main topics which we have been discussing since evening: omphalocele gastroschisis and bowel atresias. 80% of omphalocele are having associated anomalies. Those with chromosomal anomalies have a poor outcome with 40% mortality. Coming to the defect size, though the small defects recover well, the large defects have associated problems like pulmonary hypoplasia and pulmonary hypertension, which have been not looked into so well till now in India. Only when the babies are surviving that we get to see these anomalies. So this was a recent case of Kentel's pentology, whom we managed for 4 months. The baby was born to COVID positive parents and HIV positive as well. So this baby was with us for 4 months and we were trying to stabilize him for a cardiac anomaly, which he needed surgery for. However, we lost him to pulmonary hypertension and the cardiac anomaly. Omphalocele are associated with hernias. These lead to additional operations, chronic pain, and also cosmetic problems. There is a rate of 20% mortality in these patients. About 1/4 of the giant ones and 1/6 of the minor ones do have GI disorders, of which the most common is the reflux. So pathological reflux may be seen in up to more than 20% of the cases, the numbering getting doubled with large omphalocele. These will need a fundoplication in due course of time. The usual age at presentation is 7 months, often with esophagitis. 60% of the giant omphalocele do have feeding problems, and they may need a gastrostomy for feeding. They also have chronic lung disease, with 20% of them having pulmonary insufficiency. More than half of the patients with giant omphalocele will have chronic lung disease with failure to thrive. Though the non-syndromic isolated ones do well and maintain their lifestyle with their peers, 75% of being asymptomatic, the ones that have a large omphalocele are not so good. They require 3 times as many procedures, 7 times more of hospital stay, 1/3 landing up with intestinal failure, leading to neural developmental disorders. So more than 50% of them may have varying degrees of cognitive, language, and motor problems with hypotonicity and slow acquisition of motor skills. Coming to gastroschisis, though the complex varieties like having atresias, volvulus, perforation, and necrosis do not do so well, those without them do have a good outcome. The associated anomalies being 30%, those who are fortunate to undergo a primary repair without any complex gastroschisis do well. They do have intestinal malrotation, and this may be overlooked in due course of time, with some of them even coming up with malgut or midgut volvulus and may also turn out to be fatal in few of them. About 20% of them may have necrotizing enterocolitis. The cosmetic result is also a concern. So this girl we had repaired with an umbilical cord flap. At 3 years of age, she's doing quite well with a small scar. If the scar is not good or the umbilicus is sacrificed, about 60% of them may have psychosocial stress. There's another patient due to this antenatal diagnosis and a DBT project which I had for last 6 years on antenatal diagnosis. This patient was operated in the delivery suite, not even under sedation. Within 15 minutes of birth, we had put in the gastroschisis back, and she's doing well at 5 years of age with no problems at all. Abdominal problems include additional operations and chronic pain, small bowel obstruction due to adhesions, and the volvulus which I've spoken of earlier. The feeding difficulties may lead to failure to thrive and GERD, which may also lead to respiratory insufficiency. The surgical procedures that are needed in due course of time include revision of the scar, hernia repair, bowel obstruction, and even orchidopexy. There are other long-term problems associated with the parenteral nutrition, intestinal dysmotility. So longitudinal follow-up strategies are needed, which are not there at all in our country. The quality of life scores are comparable to expected, but of late, recent advances have shown that these children do have learning disabilities and they miss school very often. There is also an increased risk for auditory impairment. This leads to a neurocognitive abnormality, with known risk factors in gastroschisis being young mothers, nutritional challenges, prematurity, and repeated anesthesia. Many of them may also have retinopathy, so they need to be examined well in time. However, within first 2 years of life, these children do catch up, and after 2 years of life, they are at par with their peers with good weight, and even in developed countries, some of the gastroschisis out of 25% have also been overweight. So not all is bad. Coming to bowel atresias, there has been considerable progress in bowel atresias. The factors affecting outcome include prematurity, birth weight, respiratory distress, syndromic associations, and associated anomalies like cardiac deformities. The GIT may have dysfunction due to short length of the bowel, deficiency of mucosal enzymes, and ineffective peristalsis. Short bowel syndrome can be tackled with bowel lengthening procedures. Intestinal rehabilitation program is the way to go, where these children may be offered parenteral nutrition that may be slowly weaned off without the need for even a transplantation. Jejunal ileal apple peel atresias. In India, we hardly see any survivor of these patients, but I was very much interested in finding this article of 1997, where the author said he has never seen any mortality with apple peel atresia after 1983. So the take-home message is give parenteral nutrition, avoid an enterostomy, do a primary anastomosis, do a gastrostomy. Megaduodenum may be seen on long term with patients with duodenal atresias. So tapering duodenoplasty or chimeras may reduce the incidence. This megaduodenum may not be related to symptoms, so even asymptomatic patients may have a megaduodenum. Other complications include bile reflux gastritis, duodenal diverticular, cholelithiasis, polyps, and intestinal obstruction. We had encountered a case of megajejunum. This patient had undergone 2 surgeries in the newborn period for a jejunal atresia, which was not so high, it was beyond the mid-jejunum. He had come to us with bowel obstruction at 3 years of age. We had removed a part of the bowel with resection and anastomosis. 17 days in the post-operative period, the undilated proximal bowel had also become dilated, and we had to do a tapering jejunoplasty. These patients may also present in adulthood with jejunal dilatations, so we should warn our surgical colleagues also to look out for them. The long-term outcomes are learning messages for us. We had 2 patients in whom we did a fundoplication as early as less than 1 year of age for duodenal atresia and jejunal atresia, and both of them are doing well. There may be late deaths up to the incidence of 6%, 50% of them being due to cardiac anomalies. Thank you.
Dr. Shilpa, for bringing in short the long-term outcome. Although we keep saying that we could save a lot of lives, but they can have problems in the long term. And this should be explained to the parents in realistic counseling. Although generally it is said that, especially in gastrocases, if they survive once and they get out of the neonatal period, their long-term outcome appears to be very favorable. I have seen one picture of a footballer, European footballer, who showed a little scar of a gastrocasis. And I came across a European lady doctor who showed me a scar of her omphalocele when she was born. So I have witnessed a footballer and a doctor with abdominal wall defect. So with those comments, since we are running short of time, I would invite the Dr. Kalika to take up any questions or question answer session. I don't see any question in the chat box. If any one of the panelists would like to go ahead or discuss, or shall you hand it over to the organizers?
I would just like to ask Professor Kokila, what does she do to manage the post-operative functional prolonged, sometimes we have prolonged functional intestinal obstruction in atresias, and I think we all face that. Her take on it.
I think she has left. Professor Role may
Would you like to answer, Professor Choudhary, Dr. Sareen, anybody?
I can answer that.
Yes, sure.
You cannot do much about this. You just have to stay patient, and you have to explain to the parents. You can actually do this in a prenatal counseling already, or you do this after surgery. That might take up to 3 or 4 weeks after repairing, let's say, a jejunal atresia, before a proper transport is really seen in these patients. We don't have any experience with prokinetics or stuff like this, because I don't think this is really helpful. It's really
Not audible. Yeah. At Harding, are you people using prokinetics?
Not too much. We believe less, not too much on prokinetics, but erythromycin we have found useful, especially in gastrocases. We have seen that it might reduce the duration of your paralytic ileus days and bring them back on early feet. Other than that, we don't believe much on giving domperidone. One can try, but there is no definite, proven role of such.
For gastroschisis, some of the patients have reduced the malrotation if it's feasible and easily doable without much additions. For others, have left it as such. Do we need to follow up these patients with care, because only 3% of them may undergo a midgut volvulus? So what do you people do? Do you repair all the malrotations or leave it as it is?
For gastrocases, they have a non-rotation essentially. That's a straight gut. And if they have a non-rotation, they don't have band obstruction. And I do not see a big chance of it happening, but yeah, as reported in the literature, it can happen. But I have certainly come across necrotizing enterocolitis even 2 months following closure of gastrocases. So these are the 2 abdominal problems which can occur in them.
And Professor Role, do you have an intestinal rehabilitation program running in Germany?
Yes, yeah, we have this this is a joint venture between pediatric gastroenterologists and us. So this is at the major centers, they will have special outpatient clinics for patients after this typical congenital anomalies, and especially for patients with short bowel syndrome. But we don't
Has it reduced the incidence of need for transplantation?
It definitely,
transplantation.
most definitely, it reduced the need for transplantation. As you know, those transplantation programs, they are not really successful, because that's, as everybody knows, it's a big problem in make a small bowel transplant by the immunological impairment which we create.
Dr. Khurana, how do you counsel the patients when you get antenatal anomalies before 20 weeks? Are you muted, sir?
We counsel them before and after 20 weeks. The main thing is to really lay the cards on the table once you have all the information. There is that problem that very often for the omphalocele, we don't have a microarray report before 20 weeks, but we try our best. And even if we get it late, we say, okay, but even if we don't get any of the genetics, the first thing is to lay everything threadbare. But that's only after we've absolutely made sure that we've done as satisfactory a scan as possible. The prognosis is so dependent on the associated abnormalities that we really have to take that into consideration. The second thing is that we have to emphasize the possibility that there would be not one surgery as a magic answer to most of their problems, and it might be a longer association with hospitals for the first few years. Once you tell them that, then at least they know where they stand. The next thing they always want to know is about costs, and we do put them into touch with two types of organizations. One is, of course, the ministries which look after them in terms of supporting them for costs in the hospital. And the second thing is with NGOs that arrange the costs, because sometimes they come from remote areas and they need much more money than just hospital fee. The fourth thing, of course, is to make sure you remain in touch with them and keep giving them support as they go along, because some of these do become aware of the fact, and we always do tell them this, that look, if it's an omphalocele and everything turns out okay, don't terminate this pregnancy. It might be the only baby you ever have. And once you tell them that, then they get a little more acceptable to the idea that, yes, this is going to work. It's never an easy task. We do some of the counseling during the test with some of the findings because we want to convince them about further workup. The second part is done in a separate sitting. And I like to involve a pediatric surgeon almost immediately. That makes a huge difference. So the geneticist's involvement, the obstetrician's involvement, and the pediatric surgeon sort of come on as fast as possible.
Of late, we've had few patients who beyond 20 weeks of gestation with a congenital anomaly have gone to court to take permission for medical termination. A medical board has been set up, and we with the ultrasoundologist, radiologist, and gynecologist sit down, counsel them, make them agree that abortion is not needed. They agree, and later on they go back to the court and tell them, yes, we want to get it done.
Yes.
What do we do with that?
That's not unusual, because you see, we never counsel just a patient. We end up counseling families, and the families firmly believe that they don't want hassles in the family. And until we become a state that can actually offer support to these babies throughout, both in terms of economics as well as in terms of education, they're not going to listen. So we spend days and hours and hours and hours, and then they go back to the court and say, of course, we don't want this baby. In fact, they don't even go back, they send their lawyer back. So it's a completely different thing when they're in their family perspective.
This webinar has actually brought in the importance of teamwork and bringing everybody together. And I think we should continue like this for long. And one more thing which I picked up from Professor Udo's talk, and that has not been done only for this abdominal malformations, but for many other entities, is this centralization of some of the pediatric surgical services for some very difficult cases. That's very, very important. something like cloacal access trophy, even in high footfall centers, would not be, say, 1 or 2 cases a year. So if somebody attempts doing those surgeries, obviously the results are not going to be good. I mean, even when I was working in UK, even the access trophy bladders used to be done only in 2 centers of the entire United Kingdom. And they've noticed that, it is in Europe, even with biliary atresia, that centralization has been done, and for many other entities. So some of these surgeries are very, very difficult. Cloacal access trophy, OAS, and its management post-op, it cannot be done at every level. So I think the associations and societies and people, we should kind of have agreements on such things, and maybe we should recognize those centers who should be getting, like maybe in Delhi, there may be one center to do cloacal access trophies, so, and maybe within that center, just a unit is doing the cloacal access trophies. Then only we'll probably be able to save those patients. Otherwise, most of us can talk anecdotes and whatnot. I saved one in my 40 years of experience. That really doesn't make it any difference to that particular entity. I take this opportunity to thank Dr. Manju Puri, Dr. Manisha Kumar to involve us in day-to-day as well as in this webinar. Thank you so much.
I would like to confirm Dr. Sarin's opinion. This is absolutely a crucial approach, which is not easy, because everybody thinks that he can manage these patients himself or herself. And in Germany, there is no regulation. They would not believe that in our country. But what we do now, we do some sort of voluntary centralization of the very rare cases, like, as you mentioned, cloacal extrophies, biliary atresia, and bladder extrophy. This is actually easy, because we decide the centers which are do the most. We need 2 of them in the whole country, and we will send those patients. Last week, of course, it's heartbreaking for a surgeon. Last week we have sent the biliary atresia baby from Frankfurt to Hanover, because they are doing already half of the incidence of Germany of these babies. And it's, as you already said, Dr. Sarin, it's not only the surgery, it's the pre and postoperative workup, and it's the long-term care for these patients.
Many departments have actually started super specialization. I see in OB-GYN, I see in many other departments, orthopedics, and pediatric surgery being a very, very large spectrum, from head to toe. I mean, most of the pediatric surgeons would do everything other than bone and heart. I feel that if we within the departments also choose the consultants to kind of super specialize in one area and do just that. Let's say I pick up on Dr. Amit in our department, and he'll do only he out of the 7 of us would do abdominal malformations. Eventually, I think his experience and would really add to the overall outcomes as regards survival and quality of life later.
Dr. Manisha, you have a large series. Did you get any chance to do a postmortem of the IUDs or the medical terminations? We usually do that in AIMS if the parents allow us, but
Yes.
not for all. So have you
Yes,
gone to that
yes,
part now?
earlier we used to, I have been trained in SGPGI in Lucknow. So we used to do autopsies over there. So earlier we even had a thesis on that, and then we used to do, and I have a large series on autopsies also. But later on, our pathology department has picked up, and they are now doing the autopsies. But when I was doing it, it was good in a sense that I was doing the ultrasound also. So I knew what are the things I was getting, and then I could do the autopsy, and that would help in my ultrasound also, because I would come to know that what are the things I have missed earlier. So we had a very interesting case in which there was an ascites in the baby, and there was some cloacal abnormality we could see. So when we did the autopsy, we found that there was absent vagina, but there was a communication from bladder to vagina, and from there the fluid, the urine would come out through the fallopian tubes. The fallopian tubes appeared very large, And then there was ascites. So then we even published this, that the whole thing we could understand when we did the autopsy. So autopsy would give us answers to many things. And Dr. Khurana has been calling me. We have done heart dissections with ultrasound. So I could know that what are the things I'm seeing on image and I'm getting on the autopsy. So this I have done, and you rightly said it. Really,
yeah, because there is always a discrepancy of around 7 to 8% between what you diagnose and what actually comes out to be, even after birth. Like we had one baby who had a jejunal atresia antenatal. Postnatal baby was totally fine. But again, after a month, baby had symptoms and came back. And then again, the jejunal atresia was diagnosed. It was a stenosis actually.
Okay.
Ma'am, may I ask a question?
Yes.
Ma'am, what is the role of fetal echo in the anomaly scan, ma'am? Do you do it regularly in all the patients, or are there any specific indications to do exclusive fetal echo to rule out cardiac anomalies, because they play a very important role in surgical outcome as an associated malformation?
So as it has been said that cardiac anomalies are most common. So whenever you get one anomaly, you always do a fetal echo to see, see all the views of heart, to at least see the basic things, whether there's any cardiac anomaly or not, because that is the most common thing you will see. And then if you find both the things, then of course the prognosis would be different, because there are multiple anomaly, then the chances of chromosomal is also there. And I think sir would add to it, Dr. Khurana would add to what I've said, whether it's really required or not.
Yeah, well, you see, we must understand what the word fetal echocardiography means. The tragedy is that there are two areas in the fetus that are very difficult to image. One of these is the fetal face, and the other one is the fetal heart. And so most people doing ultrasound scans in India would not be so perfect at doing the fetal heart in detail, which is why we created a different level. Most of us who are good at ultrasound would include a very detailed cardiac evaluation, which would give you all the answers and perhaps more than what a pediatric cardiologist would do. For instance, a heart in punctology of contrail, for instance, which is completely lying off axis, can never be analyzed by a sonographer or by a cardiologist. They need somebody with a background in fetal medicine or in radiology. The same thing applies to situs abnormalities, which are often associated with this. So that's why we created this category, to make sure that someone takes a good look at the fetal heart. Unfortunately, with the fetal echo, what is also happening is that adult echocardiographers are doing fetal echocardiography, which again does not serve the same purpose. So it's more a question of semantics, words, than anything else. All we need is a good, very well evaluated fetal heart for a diagnosis. And because that doesn't happen most of the time, we add the word fetal echo to it.
Thank you, sir.
Rana. Amit, please go ahead. You complete what you have to say.
No, I was just thanking them. That's all.
Khurana, it was a real pleasure listening to you and the way you do your scans and everything. I have just one question from you.
Yes.
I mean, all things discussed, which is the specific week that you would say that the ultrasound would pick up the max?
In terms of bowel atresia?
Most anomalies. I know we are doing them on a, we talk of level 2 and all that.
Exactly.
So which one single ultrasound would you say that would actually give us maximum? Which week would you recommend?
Between 20 and 22 weeks.
Between 20 and 22 weeks.
Which is why
I ask that? Why? Because we are talking of termination. In terms of termination, yes, because that's posing a very, now we are coming to 24. I believe we are coming, I think gradually that would be passed, because it sometimes get very difficult. I recently had a patient where, it was like borderline and they were in a big dilemma. Again, spinal, along with the hydrocephalus. They'd been detected a bit late. So, I mean, that can be picked up early, but
Manju,
it was nice listening.
That brings a very vital question, which we still don't have an answer, is if a baby, because of medical condition, merits termination, if a fetus merits termination beyond 20 weeks,
yes,
other than the court, there is no way to do that.
Currently, no. But what has been done is that there is a guidance note that tells us that once the court receives a request, and this can now no longer has to go to the High Court, it goes to the District Court, then within a week, the expert committee has to give an opinion on whether it is justified or not justified.
And how late can we do the termination from the obstetricians? I mean, how late can we go ahead and do termination?
We have terminated trisomy 21 diagnosed as late as 32.5 weeks. And meanwhile, we do hope that the Rajya Sabha will put this high on its agenda, because we've already got the bill passed for 24 weeks in the Lok Sabha. And that was quite a cakewalk. It's taken us 7 years, but we've achieved that. And once the Rajya Sabha passes it, and it's pretty much high on the list on the agenda, which starts on the 9th, we'll be all very happily better off.
Yeah, thanks for that good work. Thanks for that great work. Please carry on.
Dr. Khurana, can I ask you two questions, which only you can answer? How relevant is an echogenic focus in the heart, which we see in some babies and then disappears over time? And secondly, absent corpus callosum.
Yeah, so the echogenic intracardiac focus is a marker for Down syndrome, but we also know that it occurs in a large amount of the general population, which are completely normal. And out of all the markers that we have for Down syndrome in the second trimester, this is probably the weakest. And as an isolated finding, if we do a very meticulous ultrasound examination, then we call it an isolated echogenic intracardiac focus and throw it right out of the window. The corpus callosum, on the other hand, is tricky. Not only because it keeps forming all the way till 22 weeks, but also because with a completely absent corpus callosum and the absence of a genetic defect, you can still have a very good outcome. And with a completely, not so bad corpus callosum, a little bit of dysgenesis of the corpus callosum, you can have a very, very poor outcome. So the morphology does not correlate with neonatal and adult outcomes. So counseling really becomes difficult. And it's not even a question of 10% or 90%. We have no predicting factors. And we have tried tractography, which is an MRI technique, and we have discovered that the answer would probably lie in that. And these are done on 3 Tesla or 5 Tesla MRI machines, where we try and see whether the neurons that are supposed to cross over in the midline actually go posteriorly and then cross over at the level of the occipital cortex. And that is why they have a better outcome. So I do hope that with MRI tractography becoming more mature, we might have a better answer on the functional aspect of agenesis of the corpus callosum.
Can it be done before 20 weeks of gestation?
No, the best results actually come out at 26 weeks.
Relevance of septum cavum pellucidum.
Yes, so the cavum septum pellucidum we actually use as a surrogate marker for the corpus callosum. And typically we would find a poorly formed or an absent cavum septum pellucidum when we have agenesis of the corpus callosum. The good news is that we can actually now no longer use it just as the marker, because we can actually see the corpus callosum. So what is done is, if you don't have a good cavum, or you suspect disease on the basis of something else, or in intrauterine infections, we actually do direct visualization of the corpus callosum by putting our transducer through the anterior fontanelle and delineate the corpus callosum. So it has lost its value from that point, but on a general mass scale ultrasound basis, we always use it as a surrogate marker for diagnosing agenesis of the corpus callosum.
Thank you.
Thank you all, chairpersons, for the second session. I would request Dr. Manju Puri ma'am to give concluding remarks of the CME. Manju ma'am. Dr. Manisha ma'am, would you like to say anything?
So I would really like. So I would really like to thank the pediatric surgery team and all of them, the invited faculty that we have Dr. Khurana sir, everyone. And I would just like to say that we should have more such associations and more such meetings so that we learn so much. I mean, I never knew about the long-term outcomes, and it was really very nice to hear from them. So thank you, everyone. And Aparna also, I didn't know about that polythene thing that we use for the. So I mean, whenever you used to talk to Dr. Amit and all, you used to know about these things. So this was a proper formal thing. I think ma'am has joined, so ma'am would like to say a few words.
Hello.
Yes, ma'am.
Yeah, am I audible?
Yes, ma'am.
Yeah. So thank you all for being there and making the session so interactive and
Unable to hear you.
and contribution it will be given. I look forward to more such sessions. Manisha, well done, and I'm very proud of my pediatric, fetal medicine team who is actually very, very active. So all the best. Yeah, thanks.
Thank you.
Kanika, would you like to give a vote of thanks?
Yes, ma'am. Thank you all. So good evening, everyone. I, Dr. Kanika Chopra, deem it a great honor to propose a vote of thanks on this occasion of a well-conducted webinar. So no webinar can take shape without the presence of a hardworking leader. So I would like to extend my heartfelt thanks to our director, sir, and Dr. Srivastava ma'am, AOGD president. And also it was a dedication of our leaders, Dr. Manju Puri ma'am and Dr. S Roy Choudhary, and our organizing secretary, Dr. Manisha ma'am, for making this event a big success. So I also extend my heartfelt gratitude to all of them, all the speakers who actually shared their best of knowledge with all of us. And definitely this will help in providing quality care in the fetal abdominal malformations. And a special thanks to all the chairpersons for spending their time and making us aware of all the problems that can be associated with these fetal abdominal malformations. Thank you all. Last but not the least, thank you to all the attendees for making this event a success. And at the end, I would like to thank MedGenome for their efforts involved in conducting this webinar. Thank you all and happy weekend to all of you.
Thank you.
Can I ask everyone to open their cameras so that we can have a click? Thank you, Dr. Reema, once again. Thank you so much. And thank you, my fetal medicine team, for everything.
Thank you, Dr. Manisha. Pleasure was ours. Thank you.
Thank you so much.
Thank you, everyone. Thank you, Dr. Manisha, for providing us this opportunity on behalf of MedGenome. I'd like to thank you. And if you have any questions about genetic testing, please don't hesitate to get in touch with us at our email ID given there and also our toll-free number, any of your prenatal and postnatal requirement. And we'll be sending out a recording of this to Dr. Manisha, and she will definitely forward it out.
Sure.
Thank you, everyone. And I will be ending the session now.
Thank you.
Thank you, ma'am, for giving us opportunity to serve you better.
Thank you. Thank you, everyone. Thank you.
Thank you all. Yeah.
Thank you all.
Thank you.